So welcome all after lunch for this session of workshop today. For this session, first lecture is by Professor Digambar Behra sir. Sir is Padma Awardee, Emeritus Professor and former Senior Professor and ex-HOD, Pulmonary Medicine and Dean Research, PGI Chandigarh. Sir has to his credit various national and international awards, about 9 international awards and more than 35 national awards. He is fellow of many academic societies, President of Indian Chest Society, Indian Society for Study of Lung Cancer, President-elect of National Academy of Medical Sciences, and also past President of NCCP. Sir has more than 600 publications to his credit in various national and international journals. He has written 9 chapters and about 50 chapters and 9 books. And Sir is also ex-chairman and current advisor, National Task Force for Involvement of Medical Colleges under NTEP. Sir is presently Director, Pulmonary Medicine, Fortis Healthcare, Mohali, Punjab. Dr. Behra sir shall be taking the topic of occupational asthma. Sir.
So thank you, Nitin. Very good afternoon, ladies and gentlemen. So during the next few minutes, we'll be discussing about occupational asthma. Even the relationship of asthma and occupation was known very, very long back. See, there is a description that as long as back in 1555, so they have observed that when shifting the sap from the wheat, one must carefully consider the time when a suitable wind is available that sweeps away the harmful dust, congesting the throat and threatens the vital organs. And I think, so that means there is some idea about the role of occupation and the asthma, and then subsequently the other authors, they have identified different areas associated with the occupational asthma. So for example, Ramazani in 1713, so he realized that the floor dust causes asthmatic symptoms in millers and the bakers, and then the platinum salt, chromium, phthalic anhydride. So they are the first chemicals identified for causing asthma. And in the area of diagnostics, the Pepys and co-workers, they began describing about bronchial provocation tests at Brompton Hospital, London, about bronchial hyperreactivity. So what do you mean by bronchial asthma? You see, this is a definition that was put forth in 2006, and I think it still holds good. So occupational asthma is a disease characterized by variable airflow limitation and or hyperresponsiveness associated with inflammation, which is attributable to causes and conditions in a particular occupational environment and not to stimuli encountered outside the workplace. You see, so two important things. Obviously, the first part is the definition of asthma, as you know, and then the second thing is the association. And the association of asthma is related to a specific occupational environment, and then if the stimuli were encountered outside the workplace, so relationship between the workplace, environment and asthma. So that is what basically is the occupational asthma. The American College of Chest Physicians, this is the, I think 2 years later, they made this consensus statement on work-related asthma. So here, of course, it is the same thing, but they included the various components. Say, for example, either there is a de novo asthma or the recurrence of previously quiescent asthma. That means asthma, say for example, as a child or in the distant past, that has been in remission. And if that is induced by either sensitization to a specific substance, say for example, inhaled protein, which may be high molecular weight, or a chemical of low molecular weight. And then again, please note, it is the related to work, which is termed as sensitizer-induced occupational asthma, or if there is an exposure to an inhaled irritant at work, which is termed as the irritant-induced occupational asthma. So basically asthma related to work, that is what is a part of occupational asthma. So it is the asthma which is caused by exposure to certain materials in the occupational environment. So when work exacerbated asthma is a condition, that means here there is a pre-existent or concurrent asthma that is only exacerbated by exposure at work. So the overall prevalence of occupational asthma is around 16%, and the work exacerbated asthma is about 21 to 22% of cases. So when the asthma is related to work, it can be either occupational asthma or there is asthma, but that is just exacerbated because of certain chemicals or other substances which was the person is exposed during work, but he has preformed asthma. And then there is a term which is called the variant syndromes. So then the occupational asthma again is classified as immunologic occupational asthma, that is which is IgE dependent, and they may be independent also. And then non-immunological basis of occupational asthma, that is particularly irritant-induced occupational asthma. And then, as I told you, the work-exacerbated asthma is the one when it was a pre-existing or coincident asthma. And then the variant syndromes like eosinophilic bronchitis or the part-lung asthma, so this is called as the variant syndrome. They behave like asthma. Then the non-immunologic occupational asthma, they may be acute when there is a sudden and massive exposure to that it is a single episode, and then the rats or it can occur because of multiple exposures, and it may be delayed onset after irritant exposure. It may be either acute or the delayed onset of asthma. So if it is again further simplified, so work-related asthma can be occupational asthma, which may be allergic or irritant-induced, and then the work-aggravated asthma. So this is what we discussed so far. So you see, we know the bronchial asthma that affects about more than 360 million people worldwide, and then the up to 25% of adult onset asthma is related to work. So this work-related asthma, it is a broad term, as I have shown you in the previous slides. So this refers to asthma that is worsened by the workplace. So it encompasses the clinical entities which are caused by specific agents in the workplace, which is actually occupational asthma, and then the pre-existing asthma worsened by exposure is work-related asthma. It is a major public health concern due to its important financial and societal burden and its high prevalence. You see, this may be, as I told you, it may be sensitizer-induced or irritant-induced. So the sensitizer-induced, it is usually related to high molecular weight substances, which are the diameter is more than 10 kD. These are specific Ig antibodies are produced, and in the low molecular weight chemicals, usually it is less than 2 kD. Say for example, platinum salts in refineries, rhodium in electroplating, salts of nickel, cobalt, etc. Although the mechanism is poorly understood. So the allergic rhinitis or conjunctivitis may also coexist in these conditions. So the difference between sensitizer-induced asthma and irritant-induced asthma, occupational asthma, is that in sensitizer-induced asthma there will be latency period, but in irritant-induced there is no latency period. Then in sensitizer asthma, the involvement of the host immune system that mounts a response as obvious, and in the irritant there is no involvement of host immune system. Then sensitizer-induced occupational asthma requires some time for development of initial symptoms. Usually it takes weeks to years. So and it may develop even within hours after exposure asthma. That is the irritant variety. Then allergic occupational asthma, as I said, it can be IgE or non-IgE mediated, and then irritant asthma is the non-allergic occupational asthma. So then obviously sometimes it may not be very clear. So then something is like definite irritant occupational asthma, and there is a probable and a possible, depending upon the what type it. Definite irritant asthma is the single high level, and there is a exposure, there is acute exposure, there will be no latency period. But in the probable and possible, there may be some issues, like there may be multiple small exposures, moderately high level, there will be delayed, there is a latency period, and then the repeated symptomatic exposures can occur in them. Now, seeing the, as we say, occupational asthma is the most common work-related respiratory disorder, and in USA, say for example, about 1 in 10 patients has a work history that strongly suggests there is a potential relationship. In Europe, it was about 5 to 10% in the adult population, and in young adults, it's about 0.2 to 0.5%. About the initial description says about 400 agents they are encountered in the workplace have been reported, but this number is gradually increasing, and in subsequent slides also you'll see the number of agents can be much more. So these agents, as I said, they can be divided into 3 major categories based on their pathogenesis, that is the high molecular weight agents, low molecular weight agents, and obviously the irritants. So the type of exposure to these agents very often determined by the type of asthma. So this is as I told you, the different description. These are the population studies, whether cross-sectional, case control, the cohort studies, then the theoretical or consensus. The overall, you can see the range is between 2 to 45%, and then in the different studies that give different pictures, varies between 6 to 17%, with a median of around 15 to 16% of asthmatics. And then if you, the other way we come to know that about the epidemiology, about the compensation claims that is asked for by the work-related asthma, and clinic reviews, particularly in countries where this is a occupational hazard, countries like Canada, France and England. So there are several jurisdiction court cases. From there also one can have an idea about the occupational asthma. So therefore you can see the different studies that more than, this is one of the older slides, in 1994, more than 250 agents, and then the most common type of occupational lung disease in the population-based studies. You can see there are various meta-analyses at the different years, so the prevalence varies between 10 to about 33% of cases. But the good news is that in many countries the trends in the incidence of occupational asthma that is showing a decline because of various preventive measures, legislative measures, etc. This is again these are the compensation claims also, they are gradually coming down. So that again indirectly says that occupational asthma is coming down. Then what about in India? Although we don't have got exact authenticated that data, say for example there is one description about occupational asthma in South Indian silk filatures, that was around 21%. Then the latex allergy in dental professionals, that one report from Rajasthan, that is about 16% of cases. But I think this is one of the larger studies from the National Family Health Surveys. The analysis based on 65,000 men and around 50,000 women, they are the adults. And then what the report says that in case of men, particularly the plant and machine operators and assemblers, they have got a higher odds ratio of 1.67. Then the machine operators and assemblers, they have got the highest odds ratio, and then the others like mining, construction, manufacturing and transport, they have an odds ratio of 1.33. But the other type of sub-occupations like extraction and building traders, so it is a little less. But in the women, none of these occupation categories or subcategories was found there is a significant association for asthma. So again, remember, these are the data extracted from the National Family Health Survey done between 2005. It was not a systematic survey, but this is what is available. And I think again one of the recent reports this year that shows this is the evaluating the burden of occupational asthma among individuals aged 15 and older in India. So this is a comprehensive study on mortality and disability adjusted life years. So they have analyzed that about 11,000 deaths in India attributable to occupational asthma, and then these occupational asthma deaths in India that rose by about 7.5%. And again the age adjusted mortality rate and age standardized death rate showed significant decline across all sexes compared to 1990. These are the data for 2019. So there is a reduction in the death due to occupational asthma. However, Uttar Pradesh had the highest and Goa had the lowest burden of death because of occupational asthma. And then the males and those aged 15 to 64, they faced the greatest risk of having occupational asthma. So they have suggested targeted interventions are needed for high risk regions and a population. Then as I was telling you now, I think more recent reports are saying that approximately 600 agents have been associated with occupational asthma. Earlier it was described about 250 or 400, and more agents are being identified. And then of these about 400 causes asthma due to sensitization mechanism, and more than 70% of sensitizer induced occupational asthma attributable to these 8 agents, that is wheat flour, latex, isocyanates, then the persulfates, metals, quaternary ammonium compounds, acrylates and wood. So these are the common 8 agents. They produce sensitizer induced occupational asthma. And as I have told you, they have the characteristics of sensitizer induced occupational asthma. And then the high molecular weight and low molecular weight proteins are these inducers. So these are the high molecular and low molecular weight, the difference. So by and large, the most important thing to remember is the high molecular weight agents, they have an Ig mediated immune mechanism, and then the low molecular weight, they act as an haptens. That means they are not directly immune mechanism, they need additional agents to produce a immunological reaction. Then the irritant induced asthma, these are the various agents, they have been reported to produce irritant induced asthma, and some of these chemicals you can see: chlorine, cobalt, cement, environmental tobacco smoke, benzene, then the grain, welding fumes, construction work, swine or poultry, confinement or farming. So the trade center fire that that occurred in 2001, that is again irritant induced to asthma, that produced a lot of irritant induced asthma. The in surveillance study conducted in the United States that said the top 3 agents attributable to work exacerbated asthma are the various chemicals and materials including pesticides and glues. The second group are minerals and inorganic dust, and then the cleaning material. So they account for more than 40% of all 14 categories of agents. So these are the common agents. So the other agents are the one of the important thing is the cleaning agents, and then the cleaning products frequently used around the world contain well-known sensitizers, particularly quaternary ammonium compounds, amines, and fragrances, and irritants like sodium hypochlorite, hydrochloric acid, and alkaline agents. So therefore, these cleaning agents can be attributable to sensitizer-induced and irritant-induced asthma, in addition to work-exacerbated asthma. So these are only some of the compendium of causative agents. I am not going to tell them, detail one by one, but these are the various agents they have been identified. Then these are the same thing for the irritant-induced asthma. One of the things I told you about the RADS, that is the reactive airway dysfunction syndrome. So here it occurs when there is a sudden exposure to usually massive amount of substances, exposure to an irritant, particularly the chlorines, which are notorious of producing these RADS, or the reactive airway dysfunction syndrome. So the onset is usually within 24 hours, and then there will be pulmonary functional changes like positive bronchodilator response or methacholine challenge positivity, and also there are other phenotypes of RADs. They have got different type of characteristics. So these are some of the risk factors for these occupational asthma, like if the patient is already atopic, if there is associated work-related rhinitis, if there is a non-specific bronchial hyperresponsiveness, then some genetic markers or HLA classes, tobacco smoking, skin exposure, and depending upon the amount of exposure, so they are some of the important risk factors. And then some of the new causes of immunological occupational asthma are being identified. I think that I have already indicated to you. I think one of the important things we should remember is also the role of air pollution and the occupational pollution related asthma. We know that pollution or what we call the occupational pollution is an important contributor for development of various respiratory disorders. So particularly the PM 2.5, that means particle matter less 2.5 or less than 2.5 micrometer. So they cause a lot of problems. We all know about 3.3 million premature deaths per annum worldwide, and this occupational air pollution is another crucial public health issue. Exposure to respirable dust, fumes, vapors, gases, volatile organic compounds, chemicals, and metals. This is hazardous and may cause occupational lung diseases. So that we should remember. So these are some of the other causes. I think I am not going into that. Then if you see the pathophysiology, basically there is exposure in the workspace. So either this is the sensitizer induced or the irritant induced, usually when it is high levels. So in the allergen, the sensitizer, there is a latency period, and these may be that we have already discussed, and that ultimately causes occupational asthma. So again, high molecular weight compounds, they are mostly IgE mediated. Low molecular weight compounds, some are IgE mediated, and mostly they are non-IgE mediated. Then again we have talked about complete antigens and haptens. The irritant induced asthma, I think this slide I have already shown, it is a repetition. Then some of the HLA and occupational sensitizers are identified, the HLA class and then the agents. So if they have got these HLA classes, then there is a increase in the prevalence of occupational asthma. As you can see, DQB1 or DQB1, if they are exposure to diisocyanate or western red cedar, the chances will be more. Then the most important thing is the diagnosis of occupational thing. We have got 3 or 4 steps. That is the confirmation of asthma. As like any other asthma, we know the history, clinical examination, and pulmonary function testing. Then the most important thing is the establishment of their association with the workplace. So for that we have got methods like serial peak expiratory flow monitoring or the FEV1 monitoring, then confirmation of sensitization by skin prick test or the specific IgE, and then to determine the specific etiology, we have to do specific inhalation challenge. So these are the various steps. So in the clinical, again, as I said, I think most important thing is the history of asthma prior to entering the employment and the presence of work-related asthmatic symptom. This is very, very important. And any work process that precipitates acute symptoms, coexisting nasal or ocular symptoms, duration, latency, etc. And then the workplace things also you have to see what is the size of the workforce, what is the layout, what is the shift pattern, and again the relationship of the symptoms to exposure to the workplace. That we will see here. So this is somehow it is worked out. It should be a case of asthma, of course, and then you can see whether the asthma was there before occupation or not, if it or whether the asthma symptoms occur after the occupation. And then there are certain questions, so you can have an idea. So the typical clinical picture will be the symptoms will worsen through the work week, and then symptoms improve on the weekend when the person does not go for the work, when he is off duty, so the symptoms will improve. It's a very typical symptom of occupational asthma. Then the symptoms will again recur when the worker returns to the job. So, or an accident at work involving a high exposure that cause asthma symptoms, as I told say for example, when there is certain exposure to chlorine gas. So this is in the specialized center, so we go stepwise manner that I have already discussed, that is the comprehensive clinical and occupational or environmental history, whether there is any associated disorders like rhinitis, urticaria, dermatitis, food allergy, etc. Then we have to make a asthma diagnosis through our usual reversible airflow limitation or bronchial responsiveness to pharmacological agents, and then the immunological assessment by skin prick testing or immunoblotting or the inhibition studies, and then to confirm about serial PF or spirometry recording and serial measurement of bronchial hyperreactivity, and then of course at the end they identify the culprit agent by specific inhalation challenge. So this is what, so some of these tests can only be done by specialized centers, but I think the initial 2-3 steps will be sufficient for a clinical diagnosis. So this is how a diagnostic workup is done, the clinical and occupational history with the diagnostic tests. So they may be non-specific or specific. So the non-specific tests are the lung function assessment, monitoring PFR and the serial monitoring of FEV1, then the pheno measurement, and then the sputum eosinophil count. The specific will be skin prick test, serum specific IgE, and a specific inhalation challenge, and the basophil evaluation test, etc. Then the monitoring of peak expiratory flow rate, which is very simple. So at least there should be 2 weeks at work and off work. Often it may be longer. So at least it should be measured 4 times daily, preferably every 2 hours. Then the medications allowed are keep constant and at minimum dose, beta 2 agonist on demand only, continue inhaled steroids and theophylline, avoid if possible long-acting beta 2 agonists. So this is what the typical change of a peak expiratory flow. You can see at work, when the patient is at work, it is the lowest, and when the patient is at home, that means he is not exposed to the agent, so the PFR is the highest or it is higher. So this is a typical measurement of PFR over a period of 2 weeks. As you see, over a period of 2 weeks, and that you can see at different hours. So the immunology is the specific IgE to allergen, skin prick test and serum specific IgE. Then there are, they depends on of course the which allergen is responsible. So what ultimately we said so far is the cornerstone for the diagnosis of occupational asthma is evidence of a causal relationship between exposure to the offending agent and both clinical symptoms and the physiological changes. The clinical history should include detailed questioning of the circumstances and the pattern of clinical behavior or the clinical symptom. So then these are some of the novel approaches that people have used, but I don't think I am going into those details. Then certain biomarkers also have been identified, particularly the like airway inflammatory markers following specific inhalation challenges. Then some fractional exhaled nitric oxide, of course, is very important, and that is done everywhere now. Then some sputum biomarkers and some serum biomarkers and some genetic markers have been also identified. So, but they are not, by and large, they are in the high research laboratory studies at present. They have not been used in the specific clinical practice. Then there are certain epigenetic markers and the microsomals. Again, these are experimental at this end. So then the last few slides about management, you can see the, so this is how we have summarized earlier how it should be done, how you make a diagnosis fast, and then there will be various factors that will influence the management. It all depends, there may be individual factors, there may be medical factors, and the workplace matters. Say for example, in individual, if you have a management wise, the best ideal thing is to remove him from the environment. But you have to also look into his ability to work in other roles. That should be there. Just telling is not enough. Is it possible? Then the age, that is the planned age of retirement, that is again another issue. Duration of employment in the current work role, enjoyment of current work role, financial stability, and patient needs and the preferences, what the patient wants. Then medical use, like the what do you mean by the control of asthma symptoms, or how much control of asthma symptoms. Then degree of spirometry impairment and airway obstruction, the likely prognosis, response to medication and the severity. And of course, in the workplace, you have to access to occupational health provisions, then the attitude of the employer or the management, availability and effectiveness of workplace adoption, availability of funding for retraining, frequency of exposure, the various sectors of employment, the size of workforce, and the workplace culture. All these things will decide about what should be the ideal management in a particular case. So, say for example, the cessation from work-related exposure to sensitizer, as I said, or a reduction of exposure, if it is possible, but that is the most ideal. Then the allergen immunotherapy or biologics in selected cases. Then of course, we have got a pharmacological therapy for asthma that you all know. Then the follow-up programs, particularly the change of career if it is possible. Then the medical evaluation, education, and assistance with compensation and various preventive measures. So the pharmacological treatment is not different from the non-occupational asthma, the same drugs and the same principle, and certain non-pharmacological treatment which are more important, either cessation or reduction of occupational exposure, psychosocial and financial support, and vocational rehabilitation. So obviously, large reviews have showed that most of the patients have symptomatic recovery after cessation of exposure. And however, as I have told, cessation of exposure may not be always possible. There may be severe financial and psychosocial problems due to job loss or job change. Hence, reduction of workplace exposure has been tried. There is low quality evidence that suggests that that may help. If at least the reduction, again you can see, if you reduce the occupational exposure, then some improvement occurs in about 60% of cases, and then some recovery occurs in about 18% of cases. So what should be the workplace interventions, like elimination of hazardous agents, substitution with safer agents, adequate isolation and ventilation, then administrative efforts to ensure reduced exposure timings, good work practice and employee training, ensure adequate and proper use of personal protective equipment. So the pharmacotherapy, I think, done, but the same principle as I said. Then the frequent medical checkups and screening, education of employees regarding safety measures, symptom recognition, etc. And I think the prevention, we have got both primary, secondary and tertiary prevention. The best thing is exposure avoidance and exposure reduction, whatever is possible. So this is what is the final summary, and you can see the most effective is the elimination, and then in the gradually descending order will be substitution, engineering controls, and training and behavior, and then this is the diagrammatic representation of hierarchy of control measures from the most effective at the top to the least effective at the bottom. So these are a combination of things which we have just told you. These are a series of things that have been done. It is just not only one. So the prognosis wise, there is improvement typically occurs gradually over months to years after cessation of exposure. However, most patients have only partial resolution of asthma despite cessation of exposure. So if you are interested, there are certain guidelines. This is the Japanese guideline, and I think one of the best papers I came across is the British Thoracic Society clinical statement on occupational asthma that is published in Thorax 2022. You can read that for more details. So the take-home message is there is a significant proportion of adult asthma is work-related asthma is about 20%, various figures says. Then screening and monitoring of employees is essential to detect occupational asthma early. Significant resolution of symptoms may occur after cessation or reduction of occupational exposure. Then psychosocial and financial support may be essential in patients who may have to quit or change their occupation. So thank you very much for your kind service.
Thank you, sir, for the comprehensive coverage of occupational asthma. Any quick questions from the audience? May I request Director sir to kindly felicitate Professor Behra sir.
Opportunity to thank Dr. Behra. He has been associated this workshop since beginning, and he has been the president of all the societies, that to be Indian Chest Society, National College of Chest Physician, even Indian College of Allergy, Asthma and Immunology, he was the president. Now he is the president of the National Academy of Medical Sciences. How many of you know about the National Academy of Medical Sciences? Sir, only 3. कुछ करना पड़ेगा सर ये तो. So there is a National Academy of Medical Sciences. It's one of the, I think, main academy of all the physicians and surgeons also, physicians and surgeons who are academically at a different level. Their membership is not just that you give the fill up the form and then you give the money and you become the member. No. Its membership is by election. That's right, sir? So you apply and then the people, and they have the meritorious criteria basically. And according to that, the member and the fellows of the society will give the votes for you according to your merit. So this is the prestigious society association, and this is also sanctioned by the Government of India. Directly it is linked with the Government of India. All the academic advices are given to the government through this society. So this is, I think, the first time that a pulmonologist has become the president of the society. That's right, sir? So I will request you all that go to the site of the National Academy of Medical Sciences, and if you feel that your merit is to their mark basically, then you can apply basically, because it's a prestigious. You can become the member of any society, that's fine, but becoming here the member of the society is a prestige for you. So I request all of you to just go to the site, see, and then try to become the member of that society. So thank you, Dr. Behra, for coming to this program. Thank you so much. So we continue our program. Yeah.
Thank you, sir. For the next lecture, I'll now invite Dr. Naveen Arora, sir, who is a famous name in allergy. He was Chief Scientist of CSIR IGIB with a 3 decades career and currently ICMR Emeritus Scientist of CSIR, and has various awards and honors to his name, including the Foundation Day Award to ICAI, D.N. Shiv Puri Oration Award, and he has various publications to his name. He has great knowledge in this field, and he will be talking to us about something that all of you have been talking, how the allergen vaccines have been prepared. So how to prepare the allergen vaccine for immunotherapy will now be discussed by sir. Over to you.
Yeah, thank you, Chair, for the introduction. And actually, you might have heard a couple of lectures earlier itself from Dr. Mahesh, from Dr. Nitin, from Dr. Saibal Motra in the workshop itself, and they have talked about many things about the immunotherapy, how to do it, how to make a mix, and things like that. This is also an addition to that, but you might have learnt it a little bit more. I am going to tell you is when you are making immunotherapy vaccine.
One request is there. If you can put some words how the not the skit is made. If you can give any idea that how the drops, slit drops, if it is possible, is being made. If it is possible, because lot of questions I have faced from them on the
slit.
Slit.
I'll try to say something about it towards the end, the summary part. This is actually most of the time the skit which is there is the one which is approved by the Indian agencies. The slit which is there, it has to be managed by the doctors itself. So it will depend on the mostly actually the doctors, how do they mix, what is the concentration which has to be added at that point which is there. And this can only be done once you have some experience with the skit, then only you can transfer it to the slit yourself which is there. At this moment, I don't know whether any manufacturer can give you a slit prepared thing or not, because it is not approved by the drug controller. Yeah. So coming out with the lecture itself, which we are trying to figure it out. So mostly what are allergens? So usually they are mostly proteins, as you might have seen it, and these proteins have biological functions. We'll talk about this biological functions in detail actually when I show you some of the extracts containing multiple proteins having these functions. And they are cross-reactive. Cross-reactive means they have a similar kind of a function. Because they have a similar kind of function, they can substitute one protein with the other protein when you are looking at in the immunotherapy. And each protein which is there, it's not a single protein, has a single IgE binding part. Each protein has got multiple epitopes where it can bind to a protein itself. When you say protein, it's a 3-dimensional structure. And there can be multiple epitopes on a single protein which is there, and these multiple proteins which are there, so IgE antibodies against these multiple proteins. So single protein, so if in an extract we are talking about, there must be around 15 to 20 allergens, and if there are 20 allergens in there, and out of those single protein might have around 3 to 5 at least epitopes. So when you look at extract which is there, the person can be reactive to not only a single protein, it means it can reactive to, 5 proteins, 5 epitopes into 15 proteins. There must be around 75 different IgE antibodies which may be there. This is just and what is this IgE antibody? So this is actually IgE is, which is that's a hallmark of the allergic diseases as of So it is a Y-shaped antibody. It has got 2 chains. One is the the higher chain, the bigger chain, and the smaller chain, which is we say. And this is produced by the plasma cells, the B cells, which is there. Earlier, the B cells are not doing anything. With the help of the T cells, actually, to change the thing and try to start synthesizing the IgE antibody, and which is what we say is the plasma cell, which is specifically synthesizing the B cells. In allergy, actually, this B cells which are there, actually is controlled by some of the naive T cells, which is towards the Th2 type. This is a different type of T cells which are there, and these Th2 cells secrete IL-4, IL-5, and IL-13 usually. And when you look at this biological response for this IgE, is through Fc epsilon receptor, and mostly it is the mast cells and the basophils. Mast cells are the ones which are beneath your skin, and the basophils are the ones which is in your blood mostly. There are other receptors to it also at the same time, which we say is Fc epsilon R2. They are present in other type of cells like Langerhans cells, dendritic cells, and multiple things. But the most of the things has been done. Usually, it is activity has been shown by Fc epsilon R1. Here actually is the more important factor when you are looking at the diagnostics part, which is there. Half-life of the serum IgE. One is the one which is IgE, which is in your blood. The other is the IgE, which is bound or in your to the some of the cells which is there. So when you look at the serum IgE, it is approximately 2 to 3 days, which is in your blood usually. And when it is bound to some of the cells, it can go up to 12 weeks. So if you are doing something in a blood test, so the person has to be challenged, or they're in the same environment. If a person is not in the same environment, the IgE antibodies will go down, and person may not show you the reactivity when the blood test is done by this one. And this is done usually by in vitro test, and this is usually done by the in vivo test. And when you look at the detected in the blood through ELISA, the BAT, some of the multiplex assay, I think, which might have been talked about when the in vitro diagnostics which have been done, as shown by I think Professor Mahesh. And when you look at a cell-bound IgE, it is usually done by the SPT and ID. I think you might have got some experience to it, by some hand-on experience to it, and you must be have 1 or 2 stalls around here also at the same time which you're looking at it. So what is the allergen immunotherapy? It is usually it's a type of a curative approach. I mean, it's not, I'll say 100%, remember it can cure the person completely, where he doesn't require any of the pharmacotherapy. And it's a kit usually and it's a disease modifying therapy, and what it does is to induce the tolerogenic immune response that protects the patient against the specific the allergens which are there. It's a mix of natural extracts, because all these allergens are collected either from the nature or has been grown in the lab to make this extract, and you can get a good results mostly if you mix 2 to 5 allergens. If you have more than 5 allergens, usually the therapeutic dose is not reached. When the therapeutic dose is not reached, you will find the patient will still have a uncomfortable with the same allergen itself. This is effective for a different kind of multiple settings of diseases in allergic diseases, and it is good for grass pollen, house dust mite, animal allergens, and some of the venom. And even actually it is good even for the cockroach allergen, means some of the insects allergen. Some of the studies has been done here itself in potatoes and shown this even for the insect allergen it works very well. So what happens during the response? If it is a type 1 allergy, what happens is it's a immunological response by an allergic person. So there is an allergen which is there. It goes and binds to the B cells, and what it does, it start producing the red one, which is the one, the IgE antibodies. This IgE antibody which is there, it has to be cross-linked to the effector cells, that is the basophils or the mast cells. And once they are cross-linked, and it has to be the cross-linking is very specific, which is there. it has to be cross-linked between two these Y molecules. And once they are cross-linked into the two these like this between two molecules, then only you will see the degranulation and release of the mediators, which you will see in most of the allergic cases. But what happens during the immunotherapy? It is the same allergen which is there. Now it is controlled by there is a T cell response which have been generated. What it says that T reg is a regulatory T cells which are there. And this T cells which is there, now what they do is, it's not only telling B cell to make Ig antibody. At the same time, there is a switch over from this B cell to the another type of a B cell which make a IgG4 antibodies or IgG antibodies. And this IgG antibodies somehow take care of the allergen. Once the allergen is taken care of, what will happen is there will be less molecules of the allergens which can do the degranulation, and that is how the patient becomes protected and patient gets a benefit out of this one. So in the mechanism, what happens is when you I think the low dose, a natural exposure, the APC with some of the T cells, it changes to the Th2 response, and this Th2 response give to the allergic condition. Once you give a immunotherapy, which is a high dose allergy, with the presence of that naive T cells, this APC changes the T cells to the Th1 or the T reg cells, and this Th1 reg cells, they I think produce some of the cytokines like interferon gamma, IL-10 or TGF beta, which is I think either it enhances the T reg response or the Th1 response, which either produces some of the IgG antibodies which block here, and then it blocks here at the same time. So that is how the person gets a benefit out of the immunotherapy. So factors affecting the allergen usually, when you are looking at the allergen selection, which is that's very important when you are selecting the patient for your immunotherapy. So patient history and symptoms, I think it has been talked about a lot by I think Professor Rajendra Prasad also at the same time. Allergy testing is very important because that will only tell you person is positive to what allergens. Then the clinical relevance of the allergen. What is clinical relevance? If the person is still showing or is in the same environment with the same allergen or not, or it is just showing some positivity because of some cross-reactivity or because of some other activity which is there. And then exposure. Is he in the same area exposed all the time, or if he has left that place, it is still getting some of the allergic reactions or not. When you're looking the formulating for the immunotherapy mix, which is very important, focus only on the relevant allergens. It's very important. You will find multiple positivity, but you have to look at the focus on the relevant, and this is how you have to select, going back and forth with this one. Consider the allergen quality and potency is very important whenever you're looking for the immunotherapy. Potential cross-reactivity, I'll talk about it. At the same time, what is cross-reactivity? Is the similar kind of either protein is present in different extracts, or same protein having a same function is providing different type of extracts. I'll also talk about the same thing again in this one. And incompatibility. Incompatibility is some of the allergens you cannot mix, like fungal allergens which is there, you cannot mix. Some of the insect allergens you cannot mix with other allergens, because what will happen is it will somehow denature the other proteins which is there, which is mostly, I think, it's very specific for the pollen usually. So anything you add with the pollen, these incompatible allergens which are there, most of the pollen allergen will be degraded. I'll show you some of the studies in between and during my talk. So stages of the immunotherapy, actually initial evaluation we are talking about is, for the allergy testing. Whenever you are trying to do like the allergy testing, so you have to look at either skin prick test or looking at some of the, testing in the blood at the same time. Then it comes to the build-up phase. Build-up phase is the one which is, once you start the immunotherapy, which, you start with 1 or 2 times a week, depending on the patient, and it can take a few months. After the build-up phase is, actually the focus of this build-up phase is to make it into the highest concentration which is used for the therapy part. And at the same time, this build-up phase now is coming to the maintenance phase, where you have to give once in 4 weeks or once in a month the allergen, which is up to 3 to 5 years, and depending on the patient now, if a patient gets benefit, you can, after 3 to 5 years, you can stop the immunotherapy itself. So when you say, because this immunotherapy will contain mostly the allergen extracts, which is, it's a natural material. So as I said, they are proteins, they are cross-active between allergen extracts or between different extracts itself, between different, what I was trying to say is inter and intra. When you say inter, in between, in the same extract, or it can be from a different extract. These are the proteolytic enzyme in the extract which reduces the potency. So these proteins will actually degrade multiple proteins. Once these things have been degraded, many of the epitopes are lost. And once the epitopes are lost in between, which are the IgE binding which is there, you will not get the diagnosis correctly, and at the same time, whenever the IgG antibodies have been made against this, specific epitopes, they may not be very, specific to that specific epitopes if they have not been made in that manner. Usually, to enhance the stability, 50% glycerin is the one which is to increase the shelf life, and I think most of the diagnostic material which you will be getting with SPT contains around 10% of the glycerol, and that enhances the stability of most of the allergen extracts which have been known by today. So knowledge of cross-reactivity and the biological function is very important. What do you do? What is it? Reduces the number of extracts or number of proteins in the immunotherapy well, because you want to put minimum number of the extracts in the same vial for the immunotherapy. So these are biological functions. I am only showing it here actually some examples to it, 4 of them which is there. So what is the biological function of some of the common allergens? One is the proteases. It's a large, I think, family of proteins, and you will find in multiple extracts. You talk about, its function is to it degrades the protein completely. What we say is you can find in the insects, you can find in the house dust mite, you can find in the foods, you can find in the fungi, you can find in the plant. So it's the same, I think, proteases you will find, but again there are different kinds of these ones. Cysteine, serine, aspartic, there are other kinds also at the same time. Glutathione S transferase, it detoxify the enzymes, and actually with oxidative stress regulation. So it's the same protein you will find in the insects, the food, the fungi, and the plant. And some of these, GSTs which are there, they are also present in the humans. So why not the own humans which are there? They are also being affected, because when you look at the cross-reactivity between these ones and from the human ones, it is only around 25% or so, 20 to 25%. Even some of them have a less cross-reactivity at the same time. Tropomycin, I think it is present in some of the insects and the food. Similarly, chitinase, it hydrolyzes some of the N-acetyl glucose, which is present mostly in the fungus cell wall which is there, and you can find it is present in the insect, the food, and plant. And where to get all this information from? You can get this information from different sites which are there. One is the WHO IUSI website. You can look at the allergen online. You can look at some of the STAP databases. So you can find at different places. You just go into the Google and you can find the activity, the proteins, what functions do they have, and how can be known that if they have a similar kind of function or not. So if it is a cross-reactivity between families, like if there are some trees, there are cross-reactivity, so you can reduce the weeds, the grasses, like if there are 3 grasses coming positivity, the maximum grass which the person is exposed to, or it has got a relevance to that one, so you can choose only a single grass instead of having having all the 3 grasses, because there is a cross-reactivity between these, and you will find positivity with all the things, some of the grasses. So you have to look in that way, and it can you can reduce 25% of the allergens in the immunotherapy mix, looking at some of the cross-reactivity between either the trees and the weeds. When you are looking at the chart of those, what the person is positive to. I think this is the one which I am showing to the house dust regard, because most of you will get house dust mite positivity, multiple, I think, all over India which is there. And what you see here is, this is the allergen name, and this again for the terranosis, and this is the farine. And this is, the names have been done as per the WHO IUS allergen. And when you look at these thing, see DRF1, this is the red one, this is 16 protease, this is also 16 protease. So the function of the protein is the same. So DRF2 and CP2 family, DRF3 trypsin. You look at DRF10 tropomyosin, DRP10 tropomyosin. So what it shows, both of these house dust mite allergens, they are very common to each other. Multiple of those. The one which is given in the black color, the one low molecular weight Ig1, you will not find in this one. Like DRF5 is there, DRP5 is not there. Similarly, when you look at DRF17 calcium binding protein, DRP17 is not there. So there are some unique proteins, and there are some proteins which are cross-reactive. But when you look at most of them, the colored ones which are cross-reactive, just take out the one which is the black ones. They are not the ones which are the cross-reactive. They are very individual to this one, and that is why you will get some positivity with some of the specific allergens at the same time. And there is a difference in the the reactivity from each patient to the same allergens. And you can again find out at the all those things by the WHO IUS website. Similarly, when you look at, there are two cockroach allergens usually. One is the American cockroach, Periplaneta americana, is the German cockroach, Blatella germanica, which is, both of them are there in India, which is there, and in different regions. So what you look at is, this is the one which is the alpha, Pare3 here is different one, and Blagi there is a different one. So these are the specific proteins which are there present, and serine protease and this glutaldehyde 3 dehydrogenase which is there. These are the specific protein in the Periplaneta americana and Blatella germanica. This is the specific protein. So there are some differences, but not much of the differences when you look at it, when you're looking at the specific protein of an individual thing. So this serine protease is the one which, if I have shown it is red, is only because this is the one which is very active in cockroach allergen. And what you will find out, this degrades the protein completely. And I'll show you some of the data which we have generated in the lab at this moment. So this is the SDS page showing multiple proteins in an extract which is there. And SE is the one is a standard extract. And once you look at the standard extract, so we have put these extract for different month at different temperatures. And then we looked at WP is the one which is without preservative, and the for which we look is formulation which is there, which is with some formulation. And what formulation is what we as ESEA and sucrose. ESEA is the one epsilon aminocaproic acid, and this inhibits the serine protease only. So it is one of the serine protease inhibitor. And what will you see here is 1 month to 6 months, you will find when I look at that higher temperature, something is going on off without preservative. That is what you are trying to get it. Most of the proteins have been gone down. And the same thing when you look at this is the SDS page, this is the IG Western blot which shows specific allergenic proteins in the same extract which is there. It is degraded. And once you look at after 12 months, at 4 degrees, still you get some good number of allergens, but when you look at 25 degrees centigrade, most of the allergens either at 4 degrees or 25 degrees, the things have been degraded. So you have to be very, very careful, whatever the extract which you are using for the diagnosis and therapy, are they good enough or not? That is looking at, the standardized extract has to be there for the allergen extract. So the quality of the allergen is very important in that manner. So there are different kind of proteases which are present as serine, the cysteine, the aspartate or the metalloproteases. What it does is usually disrupt the epithelial barriers in the mucosa. And once there is a disruption of the epithelial barriers, what happens is actually the allergen molecule can flow like a sieve from this one. So once they go inside easily, which is there, and once they go inside, they can activate some of the cells, or they can interact with some of the antigen cells, presenting cells, or other cellular molecules. And once these molecule cells are there, that is interaction shows you some of the inflammation, some of the airway hypertrophy, and also some of the some of the Ig antibodies being synthesized or somehow it remain, looking at the allergen presentation which happens here. So when you talk about protease immunotherapy, this is a study which has been published in 2015. So what they say is that some of the extracts are incompatible. So incompatible means that you cannot mix it, some of the extracts. What is happening is there are 3 groups. They have been divided into group A, group B and group C. So group A, which is a highly proteolytic activity, and what they say recommend is that should be given separately, like mold, insects, or some of the cockroach and so. When you look at group B, little or no proteolytic, it should not be mixed with allergens in group A. Group A is this. So, like grass pollen, tree pollen, weed pollen, tender and with, if they are themselves, you can mix it up, but not with the group A. When you look at group C, which is you can say house dust mite extract, which is there, it can be mixed with either A or group B. So house dust mite, what they say is usually little has got proteases, but you may or can mix it with this one at the same time. So this is how they have done the study, and mostly these studies have been done. Actually, they have been done usually, all in vitro studies, and mostly with the glycerol component with it. What you get is usually for the immunotherapy is usually the aqueous material. Another study which says, what they have done is they have looked at the storage condition for 1 to 3 months at 2 to 8 degrees centigrade. The red one is the one which you say you cannot have, the one mix it with each other. The ones which is the yellow ones, again at the group B time or in between, which is there, which is the risky, and the green one are compatible. So once you look at the insects to insects, you cannot mix. Insects to some of the molds, you cannot mix. And similarly, so you can see the concentration of glycerin, how it matters. See, the 10% you find, many of the things cannot be mixed. But when you look at 25%, you can mix some of them. But when you look at 50% glycerin, you can see there are only some risky things. But all the, the not recommended things, the red color has gone. So all these extracts, they are very stable, and the activity changes in what material they are. Similarly, this is another study which shows, allergen immunotherapy, what can or cannot be mixed. Again, comes out to be, the mites can be mixed with anything, as it has been shown here. But when you look at these mites, mostly they are either in a glycerin solution. So you have to be a little more careful whenever the extracts have been made. Fungi you can mix, not with the pollens, which is the red one, or you have to think about looking at the mites or looking at some of the dog hair epithelia. Similarly, insects also, which is there, you can mix the insects also, it has to be there. Fungi, you can within fungi you can mix with the insects. So the green one which is there, you can mix. The yellow one, it's something like moderate or risky. The red ones, it means you have to be very careful in that manner. So with this, actually, I will just stop here. And then the summary what I'll tell is cross-reactivity reduces the number of extracts in the immunotherapy. Cross-reactivity within the extract or within the proteins that you have to be reduce the number of proteins you can look at it. So knowledge of the biological function can improve some of the shelf life at the same time. And these are the websites where you can look some of the the databases where you can look the cross-reactivity biological functions, so you can have little more knowledge about their number of proteins, how they behave, so you can compare something like that, which I have shown you the comparison that one. With this, I think I'll stop here. Thank you very much.
Thank you so much, sir, for that wonderfully elaborate lecture. Are there any questions?
The last batch and today's batch, and if there are same number of proteins are there or not. So that can tell some of the standardization if it is good or not. Some companies they actually look at what is the last batch which is there, and when they make a new batch, how does it compare when they are looking at some of the, either you can say some Ig testing which have been done at some specific place which is there. So that is how usually done. When you are looking at from company to company which is there, so from wherever you are getting your diagnosis kit, take the extract from the same company for the immunotherapy also at the same time, because whatever is the material which you have shown the diagnosis, I think you will get good for the immunotherapy. There is no way which is there to tell us if the extract which is there is good enough or not. But yes, the only thing is, if you are getting some positivity in the patients, yes, the extract is good enough in that way. Yeah, thank you. Sure. Okay, I'll just do. So this is how usually it is prepared in the clinic, which is there. It is mostly in the PBS. Once you are looking at, diagnosis, it's 1:10 glycerol. But when it is looking at, the immunotherapy, it is the aqueous extract. Because at this moment, drug controller has not cleared anything. Drug controller says it has to be only the aqueous material, and that is how. And this is how they have been preparing it at. So mostly for the immunotherapy, it is the aqueous extract. And for diagnosis, what you will get is, I think, is the one which is a glycerin one.
Thank you, sir.
Yeah, thank you.
Thank you, sir. Moving on with our session. Next topic we have is food allergy, and for this, none other than Professor Rajkumar sir himself, who has done a lot of work on this, and he has a lot of projects, and you will hear the marvelous lecture on the topic with sir's experience and expertise. Over to you, sir, please.
इसमें है पुराने वाले में ऊपर Okay, so good afternoon, and I think everybody was waiting for this question answer for the food allergy. Okay, so why I was fascinated for the food allergy is very important, and when I joined this institute in '97, yeah, then during those maybe around 2000. So one of the patient came, she was around 12, 13 years old child, female child. Resident presented the patient. Patient was actually bronchial asthma case, and typical bronchial asthma since childhood, by birth. So resident presented me, and suddenly I saw the child, then I saw she was emaciated, lean and thin child. So I asked the mother, diagnosis was bronchial asthma. So I asked mother, इस बच्चे को खाना तुम नहीं देती हो, इतनी पतली बना के रखा हुआ है. This is the language I talked to her. Though mother says कि इसे बचपन से ही पसलियाँ चलना शुरू हो गई थी, पसलियाँ देखकर अंडर से पसलियाँ चलना शुरू हो गई थी, और घर में सभी जो परिवार के लोग हैं इसको मना किया, दूध मत खाओ, दही मत खाओ, अंडा मत खाओ, केला मत खाओ, चावल मत दो इसको, क्योंकि पसली चल रही है. उन्होंने सुना होगा जिसको पसली चल रही है उसको नहीं देना है. और तब से मैंने इसको ये सब चीज़ नहीं दिया है, तो खाने का बहुत परहेज रख के इसको मैं देती हूँ, क्योंकि हर समय प्रॉब्लम में रहती हैं. आई वॉज शॉक्ड एट दैट टाइम कि अभी तक इस बच्चे को ये सब चीज़ दिया नहीं है. देन ऑन दैट डे ओनली आई थॉट, सो आई शुड डू सम स्टडी एंड आई शुड अंडरस्टैंड. I also knew that the bronchial asthma patient should not eat this, should not eat this, should not this, during whole my life, tenure, MBBS time and everything. So then I thought, let us do some study on the food allergy and particularly in bronchial asthma. And I still remember, and I always, whenever I give a lecture of food allergy, I always remember, automatically it comes, nothing to remember, Dr. BP Singh. And at that time, I also did not knew how to write the projects. So he and Dr. Naveen Arora, who is sitting, I don't have to remember, he is here only. So these are the people who guided, rather not guided, they wrote the project, frankly speaking. Because I did not knew about that, what is food allergy and all those things. So we wrote a project on the food allergy, and I was a clinician, they were the scientists, but major help was from them only. Basic leader was Dr. BP Singh. That's right, Dr. Arora? Yeah. So, and it was like accepted by the ICMR. We got the fund around 22-24 lakhs, I think, and then we did this study basically. And in that, I still remember Dolly Kumar, so she did the PhD also. So, I am not going into detail about that. Somewhere it will come, obviously. There are many work which we have done. My whole aim and objective of this lecture is one or two, nothing else. Ki whenever you see any patient of the food allergy, then please, just for the sake of saying don't eat this, don't eat this, don't eat this, please do not do that. Because I am giving a statement, because perceived allergy by you and by the patient is this big. In our study, perceived allergy was around 60%, and when meticulously the food allergy investigation was done, the diagnosis was only in the 4%. My message is very clear. Food allergy exists, not to the extent that you or the patient perceives or know. So please, before saying to any, especially bronchial asthma patient, कि चावल मत खाओ, ये मत खाओ, 100%, be 100% sure that the patient has a food allergy, and then only you tell the patient to stop that avoidance and everything. So that is the only my objective of this whole lecture, nothing else. With that background, how to investigate the food allergy. Okay, so my topic will be like just about the food allergy, then epidemiology of the food allergy, clinical feature of the food allergy, diagnosis of the food allergy, then relevance of specific IG, total IG, component level of the diagnosis of the food allergy, component level of the diagnosis of the food allergy. I will skip because Dr. Kulwal has very nicely touched that. Natural history of the food allergy. We generally in India eat lot of rice and legume. So our work were there on the rice and the legumes also on the food allergy. Then what are the guidelines which has been published recently in last year only for diagnosis of the food allergy, and of course the last year only the management of the food allergy also was published by the Yaki, and then I will conclude. So these are the topics I will try to touch upon in 20-25 minutes. Food allergy is a adverse health effect arising from the specific immune response that occurs reproducible on exposure to a given food. So one statement is very important, that food allergy will be reproducible, means every time the person eats that particular food, he or she should have the reaction of that particular food. It's not like that 3 days back somebody has taken curd, he had a reaction, and today the patient has taken the curd, there is no reaction. It should be reproducible. That is very, very important. Whenever you take the history, reproducibility has to be there with particular food. That is one of the most important. Then only you proceed for other investigation and everything which will come. So, it's a Pandora, it's a vast, maybe a food reaction can be there, adverse reaction to the food can be there. So don't get confused with the adverse reaction to the food and the food allergy. These are two different subjects in itself. This reaction can be IG mediated, non-IG mediated, or mixture of both the results of the clinical symptomatology. Yeah, food reaction. So food reaction can be non-toxic and the toxic also, and the toxic can be because of so many factors, maybe bacterial, maybe fungal, maybe some chemical, maybe others, and then non-toxic can be hypersensitivity. That also can be allergic hypersensitivity, non-allergic hypersensitivity. But what we generally deal is the IG mediated food allergy basically. So that is a terminology which need to be done. You know, I told you that differential diagnosis of food allergy is so much, which I have tried to put it here. There are many more. So lot of differential diagnoses are of the food allergy. So before again you tell that the patient has a food allergy, you should evaluate for all of them, then only you should come to a conclusion that yes, patient has a food allergy. So, you know, it's very difficult. It's very difficult to pinpoint the other differential diagnosis and everything. Food allergy, commonly food allergy and the food intolerance. So many times we confuse for everything. Whatever the reaction is there, we will tell patient has a food allergy. It can be food intolerance. So how do you differentiate between the food allergy and the food intolerance? Food allergy is the adverse reaction that is mediated by an immune mechanism, and of course food intolerance is non-immune food reactions. Most of the food allergy are IG mediated reaction which occurs within 2 hours of the exposure. In case of the food allergy, the complaints variable and can include fatigue, brain fog, GI complications in case of the food intolerance. And of course occur consistently after the consumption of the particular food, causing functional change in the target organ. And in case of the food intolerance, it can be like symptom can be hours or post-day consumption also can be there with the lactose intolerance and everything. In case of the food allergy, severity ranges from the mild to the life-threatening. The patient can die also. In the food intolerance, patient will not die basically. It has a different kind of the reactions and so on. One of the pulmonologists, he was taking the food in the party, severe food allergy, especially to the prawns. We could not took him to the hospital. There was no adrenaline, nothing was there in the party, expired long back, around 20-25 years back. So that can be fatal. Food allergy can be fatal. You can lose the life basically. That's why the role of the adrenaline and the EpiPen is very, very important, life-threatening. You can save the life if you have the adrenaline. I will not go into detail about the mechanism. Mechanism is same. First exposure, second exposure, release of the mediator cells and the symptoms. Again, epidemiology will vary of the food allergy. So what is your predominantly, what is your diagnostic element which has been taken? Means how have you diagnosed food allergy? By history only? That can vary. By skin prick test only? That will also vary. Combine both? That will also vary. Open food challenge test, double blind placebo food challenge test. So the epidemiology also will vary. On an average, the food allergy is from 0.5% to maybe around 30 to 40%, and in case it's just a general history, it can vary to the 50-60% basically. So the percentage will vary. How have you taken, how have you diagnosed the food allergy? And so here I have tried to show the epidemiology of in different area of the world and so on. Again, I told you is whether this self-reported or how the diagnosis has varied. On an average, adult food allergy is 1.4% to 2.4%. Children, basically less than 3 years, 6%. Atopic dermatitis, along with the atopic dermatitis, 35%. In atopic dermatitis, food allergy is much more, 30%. In asthmatics, around 6 to 8% of the food allergy and so on. Then this data is have tried to show you that egg, what is the food allergy at the United States, in the world different, milk, peanut, tree nut, fish, shellfish. So all these in the United States, different percentages are there, and so on. In India also we did, and I think you'll find basically all of my research papers, Dr. BP Singh, Dr. Naveen Arora, who is here, is the part of all the papers. So rice, because the rice is consumed, so I will try to put it here that what is the prevalence. Rice allergy in the patient of the rhinitis asthma shows Ig mediated rice allergy, 0.8% of such patient. So imagine, everyone we tell don't eat, 0.8% only. In case of the black gram, it is 1.7% in asthma and rhinitis. Big 8, earlier it was big 8, these were the major food allergens: milk, tree nut, egg, peanut, shellfish. Is a world data, soybean, wheat, fish, and the 9th has been added recently, and that is sesame is the 9th one, and so on. Not lot of work has been done in India. Aero allergy, lot of work has been done in India, but in the food allergy, not lot of work has been done. There are few centers only where the work has been done in case of the food allergy, and so on. Some of the work Dr. Mahesh has done, Europreval study has been done, and where he has found the food allergy is around 0.5% and some of 1.2%, and so on. One of the data from the Calcutta which has come up, and that the prevalence of the food, that also food sensitization. Again, sensitization in the allergy is different. The prevalence of the food sensitization is increasing as compared to the earlier report, and overall prevalence was estimated to be 17% with a equal sensitizer to the cereals and the legumes. So it was just a sensitization, it was not allergy. That means skin prick test was done, and that was found to be positive. This was the Calcutta group. Is it really food allergy? There is a great discrepancy between reported and the medically diagnosed food allergy. In our case, this is the data which was published. Around 2,000 adolescents and the adults we took for this study, all were bronchial asthma or rhinitis basically, or rhinitis or both of them basically. And food allergy in these patients was around 60%. Skin prick test was done, that was 29% positivity. Then a specific Ig was done, that was 67%. Open food challenge test was done, and that was out of these 46%. And when meticulously double blind placebo food challenge was done in these patients, so overall it was 4.4%. And the rice, legumes, citrus foods were the major allergens in this study basically. So that's why I always tell, please, before you tell the patient that you have the food allergy, you should be 100% sure that the patient has actually food allergy. That's the message basically I just wanted to pass on from my side, and so on. Symptoms of the food allergy will be different depending on the which target organ has involved. If it is the skin, then urticaria, angioedema, pruritus, flushing, is gastrointestinal, vomiting, diarrhea, oral swelling, pharyngeal swelling, nausea, abdominal cramps, ocular conjunctivitis, pruritus, lacrimation. The respiratory, exacerbation of the rhinitis, exacerbation of the bronchial asthma, cough, dyspnea, cardiovascular symptoms, then cold sweats, then palpitation, tachycardia, hypotension, shock, death. Neurological anxiety, feeling of haziness, then irritability, and so on. So depending upon the which target organ, which is the target organ, the patient will start the symptoms. How to diagnose Ig mediated food allergy is very, very difficult to diagnose. The first is the history only, and history also you need to take as a detective basically, and always you have to ask whether it is reproducible or not. If it is reproducible, then only you should think that the patient has a food allergy. Otherwise, just leave the patient. You ask him to take this, no problem. So reproducibility need to be there to tell that the patient has query food allergy. And then of course the investigation need to be done. Very difficult to diagnose. It's not easy for the diagnosis basically. I will come on. So history is very, very important. History, clinical test, spirometry, skin test, specific IG. So after the history, you can do the skin test, and that also is sensitization. In case of the juicy food or juicy material, fruits and everything, prick to prick test can be also done. So then you can do the oral food challenge test. So it's a crude way of oral food challenge test. Whenever any patient comes, whenever I take this food, I have a problem. You please ask them, whenever next time you come, bring that food basically. And in front of you, let him or her to eat. It's a crude way of doing it, whether anything happens or not. So at least you will be idea that yes, he has some reaction to the food, whether it is actual food allergy or not. So that depends upon single blind oral food challenge test. So when you do the oral food challenge test, the single blind means the patient should not know that whatever has been given to eat has that particular food to which the person is allergic to. Single blind. Double blind food challenge test, control food challenge test, that means you have made the ingredient in a such a way that the patient also does not know, and as a doctor or as an investigator, you also do not know which ingredient has a particular that food ingredient in that particular that. For that, basically what you need to do, when you do the double blind food challenge test, making the recipe is also very, very important. Very, very important. That means, I'll try to just make it very clear and simple way. Whenever you see any particular food, saliva comes into your mouth. So by the sight, by the smell, by the texture of the food, you can develop a reaction. You're getting my point? And that is possible, no? Whenever your sight can also make you react basically, the smell can also react, and the texture when you take, that also can there. So whenever you are going to do the food challenge test, double blind or food challenge, maybe single also, you need to make the ingredient or the food for challenging where you need to mask sight, you need to mask smell, and you need to mask the taste also of that particular food. So making the recipe is challenge in itself basically. So when you are able to make the mask all these things, then if you do the food challenge test, then whatever the protein and the epitopes are there, if they are creating any problem, that becomes a true food allergy. Okay, but sometimes it is very, very difficult to do that also, and sometimes you get a reaction to that particular food. So that's why nowadays specific IG for some food items has come, that if the specific IG is more than this much, then probable this patient has a food allergy, so you should not go for the food challenge test, because the reaction can occur, and making the recipe itself is a very challenge. With that background, I will just come up, okay. So recommend diagnosis of the food allergy. Clinical history is very, very, very important. Diagnostics test, oral food challenge tests are also. And I wish basically this is the guideline which has come in 2023, YAKI guidelines for the diagnosis of IG mediated food allergy. So there are many things which has been changed, whatever the older perceptions were there. So you must read this. For your just information, there are some organizations like American Academy of Allergy, Asthma and Immunology, American Association of Allergy, Asthma and Immunology, European Society for Allergy, Asthma and Immunology, then in India, Indian College of Allergy, Asthma and Immunology. So you should try to become at least the member of these societies and try to go to their site, see there are many good consensus papers which are available, you should read if you want to really practice allergy and immunotherapy. That's very, very important. I will advise you, if you can go abroad also, spend some time, you can go to the conferences also, you will learn many, many things. I think Yaki is one of the best you can go. I'm not the advocate of Yaki, but I have gone many times. You can go and see what they are doing, and you will learn many, many things. So this paper, you must read this paper. It's very, very important paper if you want to practice food allergy as such. Skin prick test, I have already told. For specific IgE can be done. Food specific IgE for particular foods have been recommended latest, so that I will just come to that. So that if those are positive to that extent, then there is no need. You can just label the patient as a food allergy. Just because making the recipe, there are reactions to the food challenge test. We also got one of the reaction. I will come to that. And so for 7-year-old foods it has been given, and that can be utilized for the diagnosis of the food allergy and so on. Again, skin prick test as one of the diagnostic element of the skin prick test is there. So when we did it, so these are the skin prick test positivity, skin prick test positivity, not allergy, was there with the rice, black gram, lentil, citrus fruit, peanut, maize, banana, lima bean, peanut, and so on. Prick to prick test, I have already told about the prick to prick test. I will not go into detail about that. So then positive predictive value of the food allergy specific Ig label by the immunocap system. So positive predictive value is for the cow milk is 95% if the specific Ig is 15 K unit more than that, and in case of the cow milk 5. So for only these food items the data is there, but still I am not comfortable with the soya bean and the wheat. Wherever 100% is there, that's okay. Around the specific Ig you have done, 100% positive predictive value is there, okay, you don't go for the food challenge test and so on. So for the others, you need the golden standard is again double blind placebo food challenge test. Relevance of a specific IgE estimation in case of the bronchial asthma with a subcellular food allergy. It shows that the serum IgE of 260 international unit per ml or more with a marked positive test can serve as a marker of atopia of the food sensitization. That also food science sensitization, which we did in our study, and the specific Ig 3 times of the normal control correlates with well with the positive double blind food. So what we did, we tried to find out when we did the double blind food challenge test, we tried to retrospectively try to see what was the specific Ig, how it is correlating and everything, and we found out specific Ig in our study 3 times of the normal control correlates well with the positive double blind placebo controlled food challenges and offers evidence for the cases of the food allergy. So if it is 3 times more, that may be possible and that was proved in our studies also. Again, for the rice patients with the positive skin prick test, and of course history has to be very, very important, reproducible, then only this statement comes. So the patient with a positive skin reaction more than 4 mm and above and raise specific Ig of the serum Ig more than 6.9 shows positive double blind food challenge tests, clinical symptoms and so on. And in case of the black gram, patients with the positive skin prick test elevated Ig 4 times or more of the normal control should avoid black gram in their diet without double blind. So you need not to do double blind in these cases. That was our study which was shown. Then again we have component test. I will not go into detail about the component test. So other tests are also there, the basophil activation, mast cell activation test. So I'll just skip this. Then food challenge I have already told. Then I told you the double blind food challenge, you need to mask the taste, smell. Taste means texture also, smell and the sight of that particular food. We came out because I had a background to go to Italy for spend few days for the food allergy course. Then we, while doing the study only, we try to find out the ingredients, how the recipe has to be made, so that if we want to mask the effect of the milk and the curd, basically, if the person is so-called allergic to milk and the curd, how it has to be masked, means ki how active food and the placebo food, and how this taste, smell and the sight need to be masked, basically. So how to make the recipe, basically, for doing the challenge test was also given in this also, and which was published also. This was the study where we had around 21 patient double-blind placebo food challenge test was done. One of the patient got anaphylaxis, basically. So we need to give the adrenaline and rush to the emergency after giving the adrenaline, and the patient was managed, basically. So doing food challenge test, emergency has to be there, basically, along with you, and so on. This is the child. This also 1 year back, the consensus statement was not there for the immunotherapy against the food allergy. Last year only the consensus statement has come for immunotherapy against the food allergy. This was the child. I took the permission to show the photograph also from the child, and that was, I think, 98 or 97. This child has a problem with the black gram. So whenever, even in the cooker, black gram was boiled, the smell, she used to have the smell, and she used to trigger the bronchial asthma and rhinitis. Even when black gram was cleaned, and somehow the other it used to pour on the skin, once or twice it happened, there was a blackening, basically, there was some reaction on the skin. So much sensitive and so much allergic was there, this child, basically. So at that time, again, it was again, I think, BP Singh, Naveen Arora, Sushila, all the part of that, and we tried to see, basically, scientifically prove that the patient has a food allergy or not. It was a difficult, as a clinician, I was worried what to do, basically. If any reaction comes, then it's very difficult to manage sometimes, reaction. So for that, we were so much, I will not go about detail about the protein level making out and all those things. If I go on, then it will take two days in discussion and all those things. So I was so much worried that we diluted the antigen to do the allergy testing also. The worry was so much that we diluted to 1:5 lakhs कि इसको प्रॉब्लम नहीं होनी चाहिए बच्चे को कोई भी. So just imagine, the worry was so much कि for doing the test, skin test only. So we diluted to 1:5 lakhs, basically. With that, you can see the reaction what was there, 9:10. And then we thought, let us do with 1:1 lakh. That was 13:14. It was 4 plus 50,000, 5,000. So this much. Then again we thought, let us document the patient has a food allergy scientifically. Should not have done, but as a institute we thought, okay, this who will do then? If the institute does not do all these researches, then who will do? Who is going to do all this? So we did the spirometry evaluation. Even if you see, before we have a oral food challenge test. So you can imagine, when we did the oral food challenge test, the PFT was done before and the after. This was the before and the after, and there was a minus 64%, means obstruction, suddenly obstruction has come. So change was minus 46%, minus 64%. So that means there was obstruction after doing the food challenge food challenge test only. That was the open challenge, and of course when we try to see with the other wheat and the recipe and everything, so that was also there. And of course we try to do all the legumes, basically we try to do specific IgG, and then SDS page, allergenic bands, proteins, and all those things were. And in this patient we advocated in this patient the immunotherapy also with the lowest dilution, basically. I think 1:50,000 we started the immunotherapy, and it worked. Immunotherapy worked in this patient at that time, and that was also just for the research purpose. The immunotherapy was given in that. So what is the natural history of the food allergy? Sometimes children comes and then the pediatrician, a lot of pediatricians are there, they will tell, okay, after some time resolution may be there. So what is the rate of the resolution? If the person is allergic to the milk, rate of resolution is 50% by 5 to 10 years, 57% by age 8. If the person is allergic to egg, 50% by 2 to 9 years, wheat 50% by 7 years, soya 45% by 6 years, peanut maximum 20% by 4 years, tree nuts 4 years. So this is the rate of the resolution in case of the children that is been studied and had been put forward, basically the management of the food allergy. If anybody is allergic to any particular food, best is the avoidance. You need to ask the patient to avoid it. Another thing, if anybody is allergic to the food, because sometimes avoidance is not possible, sometimes in the packets the name of that ingredients is not written. By mistake, if you take that food, then suddenly there will be problem. So always advise, if patient is a true food allergic, always advise to have the EpiPen, Adrenaline in the pocket with the patient, so that the patient can, by mistake, if it is taken, they can save their life. That is very, very important. Management of the food allergy. This is another guidelines which has come, and that is the Yaki guidelines, because till last year I was telling no immunotherapy against the food allergy, absolutely no. But a lot of papers were there, publications were there, but the guidelines were not there. But the recent guidelines which has been published, Yaki guidelines on the management of the IG mediated food allergy 2024, that was published, where there is a the management goes like this: dietary management, psychological support, treatment plan, immunomodulation therapy, in which, in case of the dietary management, allergen avoidance is the must. Consumption of the safe food, individualized dietary advice, ideally help of the dietitian should be taken, because they know in a much better way that in that particular packet or the food, what are the ingredients which are there. Psychological support is very, very important, that coping strategy, cognition, behavior, therapy, and that should be the psychologist support has to be taken, because every time the patient is worried whether if I take this I will have the problem. So psychologically, there are many patients who has come that I am worried if I take this I will have problem, if I take this I will have problem. So the help of the psychologist is very, very important. What the guidelines has been advocated. Treatment plan, I don't know why this has come, if anybody can throw this. I think the adrenaline should have come first and then antihistaminics, but in the guidelines they have put oral antihistaminics first and then adrenaline auto-injector, of course after that inhaled salbutamol all. But still I feel adrenaline is the best choice whenever you have the anaphylaxis, basically. Okay. Then coming to the coming to the immunotherapy, basically they have advocated immunotherapy against peanut, egg, and the milk. So lot of datas are there, lot of papers are there, lot of reviews are there, and which are for the oral immunotherapy in case of the peanut, egg, and the milk. So immunotherapy can be there. There was no role of the biologicals just before 1 year back, but the recent guidelines, Yaki guidelines, has given the role of the biologicals, and that is also omalizumab has a play in the basically in case of the in case of the food allergy and so on. So I will not go about the research gaps of the evidences and all those things what need to be done. So this I will just skip. So with that I just only one objective, that yes, food allergy occurs, but please do not advise all the patients to stop that particular food and everything. Especially I will come to the another point. Whenever the patient comes to you, he will come with a lot of test of the specific IgE from the market, and they will tell that I am allergic to now potato, tomato and so many things. Then please ask, कल को टोमेटो खाया था, कोई प्रॉब्लम हुआ था? कल तो खाया तो ठीक था, जब से मैंने टेस्ट कराया है तब से खाना मैंने बंद कर दिया है. So you should take the cognizance and you should try to see if the patient has a food allergy or not, and then only you should ask the patient to stop that particular food. So there is a great difference between the public perception of the reaction and allergy of the food and confirmed reaction to allergy of the food. The patient of the asthma and rhinitis are advised to undergo appropriate in vivo as well as in vitro test before preparing, advising diet elimination. Food allergy estimates in our study was 4.47% in the adolescents and the adult with the asthma, rhinitis or both. Rice, legumes and the citrus foods was the major allergen in our study. Avoidance of the particular food is the best treatment at present. Immunotherapy to the food is recommended for the few food items. I acknowledge especially Dr. BP Singh, then Dr. Sushila Sridhar, Dr. Naveen Arora, Dr. S.N. God, Dr. A.B. Singh, Dolly Kumar, Prakriti Srivastava, Vishal Khare, Hina, and I am thankful to whatever the studies, because I have not put a lot of studies, thankful to the funding agency and Patel Chase, especially Patel Chase Institute also, ICMR, DBT, WHO and Ministry of Environment, and of course Pallabhai Patel Chase Institute. With that, thank you so much. If there are any question, I will be happy to answer. Take the mic, please. So all of my study, Dr. Naveen is there. If I am not able to give the answer, yeah, tell me. Yeah.
Sir, you mentioned about food intolerance. Food intolerance.
Intolerance, yeah.
So intolerance is not IgE mediated.
IgG mediated.
So the food intolerance test that is done in the market, the IgG mediated tests,
Yeah.
they are IgG mediated tests. How does that help in guiding the patient as to what to eat or what not to eat? What is the inference of that?
So I think whenever the food intolerance is there, so you can ask the patient to stop it, or the patient is intolerant to that, so substitute can be made. So that advice you can give, but they are not allergic to that particular food.
And usually
And IgG can be done, and they are done in the market also. IgG are done in the market also.
so for food intolerance, usually the symptoms are of upset stomach or nausea, vomiting, diarrhea.
Yeah.
Can they get oral ulcers also?
Usually not, but they can be there. But usually they will have the cramps, they will be the abdomen, vomiting and so on an average. And reaction will be not immediate, there will be no immediate reaction. But in case of the food allergy, that will be immediate on an average.
Sir, when we talk about like atopic dermatitis due to food, like it's a mixed type of reaction, na? Allergic hypersensitivity, mixed type. So what will be the history in that case for the patient?
In case of the patient who have a dermatitis, then in those patients the food allergy is more basically. And they will have the skin problem they will be having.
That is That's true. Like in IgE mediated, we say that the reaction will be within 2 hours, 30 minutes to 2 hours of eating food. So it's very easy to diagnose IgE mediated. But in cases of non-IgE mediated food allergy, like atopic dermatitis, it's a non-IgE mediated. So what will be the like manifestations? Patients will have atopic dermatitis exacerbation, but for how long? How will we characterize it with the food, connect it with the food?
Late reaction can be there in these patients after 4 to 6 hours also, on an average. रखना चाहिए. Whenever you are dealing with that, the late reaction, you should always think about the late reactions also. That is always there. There can be late reactions.
Sir, one more question. So the IgE that is tested, the serum IgE is tested by, you mentioned 2 tests, ELISA and immunocap. Are they the same or is there any difference?
I think the way of doing is different. They are almost same. There also you are measuring the specific IgE. By the immunocap system also you are measuring the specific IgE only. That's right.
Yeah, I think it is the same test which is there. So immunocap is a machine where it has been done. ELISA is usually we do it in the lab.
Different way you are doing. The modalities are different, but you are measuring specific IgE only.
Against the allergen, yes.
Against that particular allergen. There are different ways to measure the specific IgE also. You can do the manual also. So there are different ways. And the best way is through the immunocap till now. That is also important.
Sir, is it advisable to get the food allergen test, especially the crude one, which you have said about directly giving the food in a clinic setting?
Pardon?
Is it advisable to get a food challenge test, especially the crude one, in a clinical setting where you have limited
crude you can do.
infrastructure?
Suppose somebody is saying, I have a food, whenever I take this food, I have a allergy, suppose. Whenever I take egg, I have a allergy. So what kind of allergy? No, this happened, that happened, something, breathlessness occurs and everything. So be prepared for everything. You can ask the patient to bring that food. It's a crude way of doing it. In front of you in the clinic, you ask to take the food. You can see whether the patient is having any problem or not, basically. So there you can see in front of your eye only, no? So this is the crude way. Or open food challenge test, you can say. So initially open food challenge test has to be done before you go for the single blind or the double blind food challenge test. Because you have to be sure also whatever the patient is saying is correct or not. Because many times, even the sight can, have the food reaction basically. When the smell also can have. There are many theories if you see the physiology basically. Okay, so we'll discuss. We have still 1.5 days. I think 1 day, tomorrow also, today also. So that's all. Thank you.
Thank you, sir. So
Thank
next,
you.
top.
Yeah.
Invite Professor B.K. Menon, sir, for the next lecture. Sir is Director Professor in this institute in the Department of Pulmonary Medicine, and he would now be covering the very important topic of management of uncontrolled asthma.
Thank you, chairpersons. And this is the last lecture for today before the discussion. So what we'll be covering today is uncontrolled asthma, or what we call difficult to treat asthma. Basically, the control of asthma as defined by GINA is based on daytime symptoms, limitation of activities, nocturnal symptoms, and need of reliever or rescue medications, along with the lung function test. So basically, if there are no such symptoms, none of these, it's controlled. If there are 3 or more of these symptoms, it's called uncontrolled asthma. So it's defined as having poor symptom control, that is ACQ, which is less than 1.5, or an ACT over 20, And if there are frequent severe exacerbations, that's 2 or more bursts of systemic corticosteroids in the previous year. If there is any serious exacerbation requiring hospitalization, ICU stay, or mechanical ventilation in the previous year, and airflow limitation, any of this would fit into the definition of severe asthma. So if you look at it, of the allergic and non-allergic asthma, there is an overlap area. This overlap is difficult to manage asthma, and severe asthma, difficult to treat asthma, is a part of this difficult to manage asthma. It's used for those patients in which ongoing factors such as comorbidities, poor adherence, and allergen exposure, they interfere with those achieving good asthma control. So all of you in your clinical practice will be dealing with asthma patients, because it is one of the most important allergic diseases which you would be encountering. So there will always be 1 or 2 such patients who are not getting control despite you giving the best medications, despite you changing as many medications, companies, types, inhalers, all these things. Even then the patient is not able to achieve good control. So that's what this lecture is about, what you are going to do in these patients. So treatment resistant or refractory asthma, they refer to patients with a confirmed diagnosis of asthma whose symptoms and exacerbations remain poorly controlled despite giving high dose corticosteroids. So when you see the GINA chart, it says you should be using high dose corticosteroids, and of course the step 5 would be including other things, of course. So you use high dose corticosteroids plus a second controller such as a LABA, and the management of comorbidities or whose asthma control deteriorates when this treatment is stepped down. All this is called refractory asthma. So severe asthma includes these patients and also those in whom the treatment of comorbidities is incomplete. So it encompasses all this. Severe asthma, along the causes include wrong diagnosis, comorbidities, and other patient factors. So what's the reason for poor control? Wrong diagnosis is very important. So you have to rule that out first. Confounding illnesses may be there. Your inhaler techniques, your choice of inhalers may be wrong. The patient is not able to use that particular kind of inhaler which you have chosen for him. Patient may be smoking. There may be other things like rhinitis, non-adherence, which may be intentional or unintentional. Then there may be individual variations, and of course you may be underdosing the patient as well. So this mnemonic simples, that is smoking, inhaler technique, monitoring, pharmacotherapy, lifestyle management, education and support. This is what you need to do when you encounter a patient with poorly controlled asthma. So how do we measure the asthma control? You take a good history, you review the prescription, you use some questionnaires, and you use some objective methods. There's several simple tools available which help you, tell about the control of asthma, like the asthma control test, the asthma control questionnaire. These are the commonly used two questionnaires which we would use. The goals of assessment would be to confirm diagnosis, to maximize inhaled therapy, optimize adherence, and assess the asthma control. While those of management would be to maintain normal activity levels without symptoms, reduce risk of exacerbations, fixed airflow limitation, and medication side effects. So a difficult asthma clinic basically has the aims of providing a diagnosis, assessment, phenotype the patient, and manage these patients. How do you confirm the diagnosis? First of all, rule out misdiagnosis. Objective confirmations by use of a spirometry with or without bronchodilators, a bronchoprovocation testing, and a PF variability. Comorbidities such as nasal disease, gastroesophageal reflux disease, vocal cord dysfunction, COPD, bronchiectasis, OSA, anxiety, depression, obesity. All this has probably been covered before. So these are what you would have to rule out in this case. So all these diseases have been associated with asthma, and prevalence varies from 40% in AR to 70% in about OSA. And treatment improves asthma as you control these comorbidities. You optimize adherence by giving management skills, reviewing the inhaler technique preferably on each visit, checking the adherence to medications, encouraging self-monitoring by the patient, giving the patient a written action plan. What's to be done when there are problems, how to increase the dose of his medications, when to use rescue medications, and when come to the doctor. Educating the patients, and of course going in for smoking cessation. Phenotyping is another important step which you could do, which can help the patient, control the patient. So there are different types of phenotyping. One of it is cluster analysis. So this varies depending upon the atopy, age of onset, lung function, and medication needs. The other type would be by using biomarkers. So you'd use biomarkers like sputum eosinophils, blood eosinophils, pheno, and other such techniques. So basically the asthma syndrome, I think this is phenotyping has already been covered, so I'm not going into detail. The asthma syndrome gives a number of distinct asthma phenotypes based on clinical features such as atopic, obesity related, early onset, late onset, severity and comorbidities. Then on the lung function, like fully reversible, non-reversible types, inflammatory types like Th2 versus non-Th2, based on induced sputum like eosinophilic, neutrophilic and paragranulocytic, based on biomarkers like IgE and eosinophil count, and based on pheno. So you are based with a number of phenotypes which can help you make a better choice of medications to help the patient. So for instance, if there is severe asthma with raised IgE, you would consider omalizumab. If it's eosinophilic, you would consider mepolizumab or Benrali, and non-eosinophilic is a separate thing where there is no medications essentially for it. All this has been now incorporated into GINA into step 5. So many of these medications have been covered in GINA step 5. So what do you add? If a patient has poor control of asthma, you could change the ICS. You could try and use a fine particle ICS such as cyclisonide. You could add an LABA to it or a LAMA to it and an LRTA. For selected groups where you have evidence through biomarkers or other places, you could try anti-IgE therapy like omalizumab or anti-IL-5 like Mepali can be used in such cases. One drug which is very effective in severe asthma are LAMAs like tiotropium. It's something we use in COPD, but it's something which you could use in asthma if it's being poorly controlled. So it's been shown to improve FEV1, reduce SABA use and reduce the risk of exacerbation. Of course, it's important to remember there is no evidence in children for this medication. Montelukast is not as effective as LABAs when added to ICS, but it improves lung function, and some phenotypes like aspirin sensitive and exercise induced asthma have been shown to be more responsive to Montelukast. Macrolides are not recommended at all, but in some trials it has shown to reduce exacerbation rate, and specifically in that subgroup of non-eosinophilic asthma phenotype, it has been studied because there are no other drugs in that group. It's not recommended and it has uncertain clinical benefits, so do not use it except for research. Anti-IgE has been well established in the role in allergic diseases. I think it has been covered well in detail, so we are not going into that. It basically prevents the IgE from binding to the receptor on the cells. It's indicated for severe allergic asthma. It's expensive. A 4-month trial should be given before any kind of long-term therapy is considered. Bronchial thermoplasty is another such technique which can be useful in severe asthma. Done in 3 sessions, it basically the less smooth muscle mass in the airways would mean less airway constriction, and it helps in achieving better asthma control. Again, GINA step 5 includes bronchial thermoplasty now as a modality for control of asthma. Of the biologicals, which again has been covered in detail, I think, basically you reduce the side effects of ICS, and there are different biologicals of which mepolizumab and benralizumab are available in India today and are being used also and can be considered in selected patients. So if there is severe allergic asthma with high serum IgE, you would think of an anti-IgE medication. Eosinophilic asthma, you would think of an IL-5 kind of a medication. Neutrophilic asthma may be macrolides, but not recommended, of course. Chronic airflow obstruction, you would think of bronchial thermoplasty, things like that. So the definition of severe asthma must be confirmed, adherence must be optimized, medication should be high dose ICS plus LABA or LRTA, systemic corticosteroids may be used, and uncontrolled asthma would mean poor symptom control, frequent exacerbations, severe exacerbations and airflow limitation. This algorithm covers just what we covered previously, how you go ahead and control it. You confirm the diagnosis, see patient is not smoking, if he's using inhalers correctly, if he's adherent with treatment, any alternative diagnosis is there, comorbidities are ruled out, and then look for other substances at home which needs to be excluded. Then any drugs which may cause bronchoconstriction. Does the patient have a prescription of high dose inhaled corticosteroids, and add LABA, LTA, etc., and review the patient frequently. When to review? a 1 to 3 monthly review after treatment initiation, and step down if the patient has been stable for over 3 months. The aim is to give the minimum dose, and stopping ICS is not recommended in patients with asthma. So in summary, difficult asthma is challenging. Systemic assessment and management should aim to control symptoms and risk reduction, and consider alternative add-on treatment if possible. Thank you. Any questions? Thank you.
Thank you for the wonderful session, sir. And now this session comes to an end. So now I request Dr. Nitin to felicitate Professor Naveen Arora, sir, with a memento. I request Nitin, sir, to felicitate Professor Menon, sir. Thank you, sir. Thank you, sir. Now we all break for tea for 10 minutes and we'll be back for case discussion.
All right. सब आ गए? Check कर लो एक बारी. So I'll ask all the faculties to come on the dais. Bala, come. सबको बोलो आने के लिए. टाइम लगेगा नहीं? So okay. हाँ डॉक्टर प्रशांत कम. सब आ गए क्या? उधर नहीं है कोई? So, how many cases should we discuss? Accordingly, I will plan my one, है ना? नहीं, all of you has to tell, no? Two. So accordingly, I will choose what are the two cases I have to discuss. So 2. Okay. So half an hour, 45 minutes, 40 minutes? Half an hour. As though today is not raining, so you might go for the shopping and all those things, no? Hai na? Very good. I know. So because tomorrow you have to go home, so you will buy something for the home. It's very difficult to keep away from house for so many days basically, sometimes, no? Anyway, so what we'll do, so some of the cases I will directly discuss and not going to ask you the questions and everything. This is the patient. He is a physician. तुम लोग थे उस समय? नहीं थे. हाँ. So he is a physician. He is a surgeon, and so he had a bronchial asthma, and whenever he used to go to the farm he had a exacerbation of the problem. And when we ask you what kind of the farm is there, what are the trees or the weed or what are the type of the trees are there, so ultimately he told that he has a farming of the cannabis basically nearby. So whenever he used to, typical symptoms where whenever he has the exposure to that, he had a exacerbation of the problem, and several episodes of anaphylaxis. He was a surgeon. He used to tell that whenever I have exposed, load was more at that time, anaphylaxis, and he developed reaction. Then we thought, let us go for the skin prick test with the cannabis, and the cannabis came to be positive. And then we gave immunotherapy to this patient. I had a video, but today I have not brought it. So he developed, he was strongly positive, and then immunotherapy was given. And immunotherapy was given again as we give 1:5,000, 1:500, 1:50, and so on. And accordingly, he was managed basically, and the symptoms were reduced basically. And now he doesn't come. I have a contact on the phone because he calls me always. Whenever he comes to Delhi, he talks to me also. He is perfectly fine basically. He is not requiring SOS. Sometimes Astelline he takes, otherwise he is not taking any regular medication. This is the data which I think Mahesh also showed. So some of the patients which we went for inflammatory response to the subcutaneous allergen immunotherapy in bronchial asthma and rhinitis. And in this, again, these are the datas where polymonoallergic patients were given immunotherapy, and they were followed basically 1 month, 3 months, 6 months, and so on. IgE, specific IgE, then interleukins also. And you can see the especially we did the IL-5 and 6, 5 and 6 which we did, and that was in the 3rd month only that there was a reduction, and 6 month more reduction was there. So although these are not to be done, and this 5 and 6 we did at 0 month, 3 months, and the 6 month followed was there. Again, I have data 12 month also we had done, and for 15 months also we did this. So with that background, we'll come to the second case, and this case is 22 years female student presented with the complaint of breathlessness, cough, rhinitis for 8 to 9 years. Used to have exacerbation about 6 to 7 times in a year. She used to take inhalers but was not regular in the medication. Symptoms were perennial with more occurrence during the kitchen and the storerooms, which we discussed yesterday. Used to aggravate during the house dusting and the opening of the old papers, and the problem used to be more in the home. No family history, and the diagnosis was made in this case bronchial asthma and the rhinitis. So like anybody, if he anybody, I will not spend time now, but anybody wants to give his or her comment on this patient. So what next, what need to be done, what are the allergens to which we should be doing the test, because all the history we have put it. थोड़ा wait कर लेंगे आधे घंटे. हाँ. So anybody wants to tell anything? Anyone? I know everybody is tired, but still. You want to say something?
SPT for house dust mites.
So SPT with house dust mite. Okay. Anything more? Because
Cockroaches.
house dust mite, cockroach, and anything? Any more? So anyways, I will go beyond that, and then the allergy testing was done with this, and this is the skin prick test which was there. So any interpretation anybody wants to give for this? Any interpretation with the history? What, suppose this is the positive result which is there. So anyone wants to give his opinion, her opinion about this, and then if at all the immunotherapy to be given or not, if at all given, to which antigen the immunotherapy should be given. Anyone? If not, Haji? जोर से बोलो, नहीं सुनाई पड़ रहा. Mosquito, okay, mosquito. So if you interpret all the tests, the histamine is 5 into 5, then buffer's line 1 into 1. So any size more than 4 should be taken as a positive in this patient, and so ultimately the mosquito 11 into 5. So this is positive only. So immunotherapy was given again with the 5.5 ml of the mosquito antigen, and of course this is the immunotherapy chart. All the dates are there. It's not visible clearly, but the charts are given. Again, these things not to be done, but for the research purpose, if you see this size prior to, then I think this one, the diagnosis was made in October 2012, and then we followed up the patient, wheel size, and just for my curiosity's sake, all the questions you people ask now. So I thought, let us do the skin prick test to see what has happened basically. You need not have to do. So here, if you see, I have done the test and everything. So almost whatever the earlier test was this. So it was 2 into 2, it has become 0. It was 2 into 2, it has become 2 into 1. It was house dust 3 into 3, 2 into 6. Then cockroach 3 into 2, it has become 0. Then cockroach 3 into 3, then it has become 0. House fly 3 into 2, it has, so almost all the wheel size has decreased basically. And if you see mosquito, it was 11 into 5 basically. And mind it, we used the same antigen brand, means from the same company, so the difference was not there. So it was 11 into 5, earlier it was 4 into 5, so that also has different. Moth has slightly same, or it has increased. So that means, of course, there is an effect on that, but still, basically, these recommendations are not there for follow-up patients. And the same way, the interleukin 4, 5, 6 was done, and the patient was followed up for 15 months. So every 3 months, the interleukin tests were done. So means for the research purposes and everything you can do, but still, again, I am repeating it, no recommendation for doing all these tests. So coming to the another case, this patient is 25 years old, male, cough, breathlessness with a wheeze, 8 years, receiving low dose of ICS, LABA combination, SABA, seasonal use, intranasal corticosteroids, repeated cold for 10 years, then perennial symptoms with seasonal exacerbation in the March, April, September, November. Triggers are indoor and outdoor. So suppose if we look at this patient, so it has a perennial symptoms, and then there is a exacerbation during March and April and September, October, November, September to November. So I was just telling you, I will just say something about the history. So history taking is very, very important when you are dealing with perennial, seasonal, whether it's in the office, it is in the day, night, morning hours, what are the aggravating factors, what are the relieving factors. Again, if more in the outdoor, the culprit is pollen, insects, or the occupations. More indoor, house dust mite, insects, all repetition, but these are very, very important when you take the history. Again, winters, cotton dust, wool dust is very, very important because you open the wool and all those things. Summer, dust, insects, pollen, rain, fungus, insects. Coastal area, fungus, coconut, farming area, all the fungus basically. Air pollution, of course, becomes triggers or irritant also, and the allergenicity of the pollens also increases this. Change of season, if there is a problem, pollens. Perennial problem, dust, mite, insects, dander, feathers. Hilly places, lichen, hilly plants. In the plains, pollen, dust, insects. Daytime problem, maybe occupation related, pollens, insects, dust. Nighttime, cotton, insects, exercise induced, and so on. So these are the, again, pollens. If they are in the spring, March to June, the main culprit is tree. May, August, grass. October, August, weeds, mold, house dust, fungi, pet, house dust mite, cockroach. You know, if you see, this is a beautiful slide basically, and where you can see the fungus is, if you see outdoor basically, the fungus are prevalent throughout the year, but the maximum intensity is from May, June, July, August, September, October. And if anybody has a problem, March, April, May, tree pollens are the culprit. June, July, grass pollens are the culprit. And August, September, October, the weed pollen. So this, if you keep in your mind, so there are many questions which are there in the mind for selection of the antigen, that will be clear by this, by seeing this slide and so on. Common indoor, outdoor, there is a guidelines which is there, so you can just go to the guidelines and see everything. This is a, I think in the guidelines also this chart is there, no? In the guidelines, I suppose the chart is there. I don't know. So they is there in the Googles also. So you can just download this and accordingly you keep in at your table. So you'll be able to know basically if the month wise you can able to know which are the allergens which are there, weeds, grass, pollens, fungi, then again dust, insects, feathers, danders, so all wool, cotton and all those things. So these can be there. So selection of the allergen again. So coming to that patient which we discussed. So the patient has a problem basically in the, say perennial symptoms, exacerbation in March, April, September, November. So if the perennial symptoms are there, then this slide will tell, okay, perennial symptoms are there, the culprit may be dust mite or the cockroach. Okay, seasonal pollen or the mold. So we have to find out if the pollen, which pollens are there, which mold is there. Problem is the March, April, September, November. In this, the patient's allergy test was done, and if you interpret this allergy testing and everything, your perennial symptoms, that proves basically house dust mite is positive. That's right. So I have ticked it. So house dust mite, okay, there's no confusion about that. So perennial problem is solved for me. So seasonal, so I have to see Cynodon, Artemisia, Aspergillus, and of course cockroach, because this also will come, house dust mite and the cockroach both has been given there. So perennial problem, perennial is, I have matched it basically. So that becomes a significant. But I need to see that whether all these three are significant or not, seasonal symptom. So again, what I need to see, I again go to the calendar and try to see if Cynodon, then Artemisia and Aspergillus are matching with the history or not. So if you see the prevalence of the pollens of Cynodon, Artemisia and Aspergillus, it's not matching basically. If you see, it's not matching. So for this patient basically, house dust mite becomes the one of the, I think Cynodon is matching. That's right, na? Cynodon is matching, yeah, that's what. Though, if you see, the patient has a problem in the month of March, April, September, October, November. Okay? So Cynodon is perfectly matching with the history of the patient. Then Artemisia, only the problem is in the only these are available in the month of the September, so it is not matching. In case of Aspergillus fumigatus, this is also not matching. Maximum is in the June, July, August. So this is also not matching. Only the Cynodon matching. So two allergens. If you see, if I go back to this slide, so perennial symptoms, dust mite, cockroach is matching, and seasonal symptoms, Cynodon is matching. So out of this house dust mite and the cockroach, I need to take one house dust mite. And in case of the seasonal symptoms, pollens, I need to take Cynodon. So that's what basically has been done here. The positivity was almost same. So 50% of the Cynodon has been taken and 50% of the house dust mite has been taken for this, and of course the response was there. Then I just, okay, this is also very important, but I'll just let you people discuss this. Okay, so coming to the 21-year-old student was diagnosed with the asthma as a child, but has no episode of wheezing or cough for more than 8 years. He is an outdoor enthusiast, does not smoke, is on no medication, started experiencing symptoms after moving to the hostel. He has been awakened by the cough and average for 3 nights a week and has symptoms since last 2 months. Family history include dust surrounding, exposure to the cat. Okay, so with this history, anything you people want to ask, you can ask me, anything. Any question? I think now more. Anji.
2 months है, but yeah, easy experience throughout the year or just 2
Pardon?
months? Like the symptoms are only for 2 months or easy experiencing throughout the year?
I'll read again. 20-year-old student was diagnosed with asthma since childhood but had no episode of the wheezing and the coughing for more than 8 years. For last 8 years, he did not had any problem. And 8 years back, actually, he has shifted the house. He had come to the new house. And then the patient has been shifted to the hostel for last 2 months. And now he has the problem.
Okay, so
Pardon?
dampness in the hostel, damping, dampness in the hostel.
Dampening in the house. There is no dampening in the house.
Hostel.
Haji? हॉस्टल में हॉस्टल जैसा हॉस्टल है
The bedding of the
रूम में
hostel.
डैम्पनेस नहीं है
So is the bedding of the hostel the same or has it been changed?
मैं बेडिंग घर से लाया था
सर हॉस्टल सेम सिटी में है क्या?
पार्डन
सेम सिटी में हॉस्टल है क्या?
सेम सिटी में नहीं दूसरी सिटी में है
Timing of the year.
पार्डन
सर वहाँ बहुत प्लांट्स तो नहीं है हॉस्टल में ट्रीज
हॉस्टल में प्लांट्स नहीं है घर में हॉस्टल के अंदर बाहर है गार्डन है बाहर
So which month of the year he shifted to the hostel? The time of the year?
जस्ट 2 months back only
Year of the month, means month of the year.
month of the year I don't remember
There is history of exposure to cat. Does the cat belong to this student only or his friend or colleague?
exposed to everyone
No. It's a stray cat.
yeah
So, are his friends also exposed to the same cats?
हाँ
They also suffer the same symptoms?
हाँ So would you ask any additional information for the clinical history? Which allergen should be chosen for the test? What would be the next step for the diagnosis? Okay. So again, whatever the questions you are asking, I will try to come out with the answers only. On further history, it was asked, was there a cat exposure throughout the childhood? The cat exposure stopped at the age of 12, 9 years back. So the patient became asymptomatic for last 8 years. If you go to the history, for last 8 years, no episode of the coughing. Since childhood, the patient has a problem. After for 8 years, there is no wheezing, coughing for last 8 years. And as soon as the patient has shifted to the hostel, the symptoms improved significantly after moving to the new home. The symptoms recurred only after moving to the hostel, where there was a cat. So in this, the test was done, and the test was this. Anybody can interpret this? House dust mite, it's positive. Cat dander positive. Cow dander no. Shrimp no. Artemisia yes positive. Cockroach positive. So what are the significant allergens in this patient basically? So in this, if you see, the cat is the important, because as soon as the cat is out, the symptoms were not there. As soon as the history says hostel she has shifted, there is a cat at the hostel and the symptoms have increased. So cat avoidance and everything, you must be knowing about the avoidance. So you can go ahead with the avoidance. Again, I will just go to the another case where I think the patient is going to tell you. Yeah. So this is a patient which Veena Malik, 45 years. This will be the last office worker. Episode of the cough 20 years. Repeated cold for 20 years. 1 to 2 exacerbation per month round the year. In total 12 to 15 exacerbations per year, resulting in the nasal block, headache, sneezing, itching, then around nose, throat, and the coughing. Routine investigation was done, and all were, I think, normal. And then diagnosis, since this patient has a only nasal symptoms, so the patient was diagnosed as a allergic rhinitis. Then they started pharmacotherapy, but patient's symptoms were only partially controlled. Most of the exacerbation occurs while at home, during the dusting and the cleaning houses, occurs whole year. We suspected indoor allergen and planned to do the skin prick test with the 68 allergens here. That should not be done, so accordingly you have to select the antigen to which the test has to be done, and the test was done. And this the cockroach insect was positive in this case. Immunotherapy was given in this patient as per the guidelines. These are the OPD scores. And then I just wanted to show you that how detail you can take the history, and then
मतलब एक महीने से डॉक्टर से मेडिसिन ले रही थी और मुझे 650 mg की क्लेम मॉक्स देते थे, इतनी हाई एंटीबायोटिक से भी, बट कोई रिस्पॉन्स नहीं था उनको उस दवाइयों का। और सिरप भी लेती थी, गर्म पानी पीती थी, बहुत कुछ करती थी, लेकिन मैं इतनी फेडअप हो चुकी थी ना कि अपने हस्बैंड से कहते थे कि आप मुझे किसी हॉस्पिटल में एडमिट करा के आ जाओ, इन डॉक्टर्स की दवाइयों से फ़र्क ही नहीं पड़ रहा। फिर एक हमारे ब्लॉक में अपार्टमेंट में डॉक्टर रहते थे, उन्होंने बोला कि आप ना पटेल चेस्ट में जाइए, आप वहाँ प्रॉपर सारे ट्रीटमेंट कराइए, वहाँ बहुत एक्सपीरियंस डॉक्टर है, वहाँ दिखाइए आप। उन्होंने मुझे रेफ़र कर दिया। फिर मैं जब यहाँ पे आई तो मैंने फिर यहाँ बताया अपनी सारी हिस्ट्री, तो उन्होंने मुझे स्टार्टिंग में पहले एक मेडिसिन दी 5 डेज़ की और नज़ल स्प्रे दिया, क्योंकि मुझे जो स्टार्टिंग होती थी वो जुकाम से ही होती थी।
ठीक है, मैं समझ रहा हूँ बात।
हाँ जी।
सिर्फ आपको और पूछूंगा मैं, जो आप जब आई थी उसमें खांसी थी आपको 20 साल से, है ना? और नज़ला जुकाम भी था?
हाँ जी।
नज़ला जुकाम भी 20 साल से था?
हाँ, मतलब बीच बीच में होता रहता था।
बीच में जो था,
हाँ।
कोई खास मौसम था जिसमें नज़ला जुकाम बढ़ जाता था आपको?
विंटर में ज़्यादा होता था।
विंटर में ज़्यादा होता था।
विंटर में और डस्ट वस्ट से बड़ी
कब होता था? नाक बंद भी होता था? हाँ, नाक बंद भी होता था। और नाक से पानी वगैरह भी गिरता था? अच्छा, ये जो प्रॉब्लम थी आपको, नज़ला जुकाम, छींके, कफ, जो घर में जैसे डस्टिंग वगैरह हो रही है, सफाई वगैरह हो रहा है, घर में उसमें बढ़ता था, क्या क्या कारण था जिससे इससे आपको प्रॉब्लम बढ़ जाती थी?
एक तो डस्ट वगैरह से, जैसे हम घर की सफाई वगैरह करते थे या कुछ भी, जैसे जो जिसमें भी धूल मिट्टी वाला काम होता था उससे मुझे हो जाता था बड़ी इजीली, बहुत जल्दी हो जाता था।
क्या शुरू होता था, क्या होता था?
सबसे पहले जुकाम में होता, छींकें आनी शुरू हो जाती थी, नाक बंद हो जाता था। उसके बाद फिर जब मैं उसकी कोई मेडिसिन लेती थी तो वो खांसी में चेंज हो जाती थी और फिर वो खांसी ठीक ही नहीं होती थी।
नज़ला जुकाम से पहले शुरू होता था और फिर खांसी हो जाती थी।
मुझे एवरी मंथ डॉक्टर के पास जाना पड़ता था।
सांस में कोई दिक्कत होती थी? सांस तो नहीं फूलता था आपका?
नहीं,
सांस कभी नहीं फूला। अच्छा, और घर में किसी को तकलीफ है इस तरह को? पापा मम्मी किसी को भी तकलीफ है? अस्थमा की प्रॉब्लम थी। वीना जी का हम लोगों ने पहले हिस्ट्री लिया, हिस्ट्री लेने के बाद हम एक नतीजे पे पहुंचे कि इनका रूटीन जो इन्वेस्टिगेशन है वो करें। रूटीन इन्वेस्टिगेशन जो HB/TLC DLC वगैरह होता है वो सब नॉर्मल था, कोई दिक्कत नहीं उसमें। हम लोगों ने एक पल्मोनरी फंक्शन टेस्ट किया, जो पल्मोनरी फंक्शन टेस्ट इनका नॉर्मल था, क्योंकि इनको ज़्यादा नज़ला जुकाम ही सिर्फ था। फिर भी हम लोग चाहते थे देखना कि इनका जो PFT है वो क्या है पोजीशन, बट PFT में ऐसा कोई FEV1 FVC और FVM में FVC रेशियो नॉर्मल था। फिर हम लोग सोचे कि ऐसा कोई हो सकता है कि इंडोर एलर्जेंट हो जिसकी वजह से इनको प्रॉब्लम हो, तो हम लोगों ने इंडोर एलर्जन के लिए, लेकिन पटेल जिसमें हम लोग सारा कुछ कराते हैं, तो इसलिए हम लोगों ने 68 एलर्जन के थ्रू हम लोगों ने टेस्ट कराया। तो हम लोगों ने पाया जिसमें कि जो कॉकरोच और मॉस्किटो और मोथ से पॉजिटिविटी थी, लेकिन हम लोगों ने जब रिपीट कराया तो पता चला कि कॉकरोच से इनकी पॉजिटिविटी बहुत ज़्यादा थी। और जब हम लोगों ने मैच करने की कोशिश की, हिस्ट्री मैच करने की कोशिश की, तो इनकी जो इंडोर एंटीजन की वजह से प्रॉब्लम लगता था कि एग्रीवेट होती है। तो हम लोगों ने लास्ट में फिर डिसाइड किया कि इनको हम कॉकरोच के अगेंस्ट इम्यूनाइज करें। हम लोगों ने ऑर्डर प्लेस किया और हम लोगों ने 1:5000, 1:500, 1:50, इस तरह से शेड्यूल लेकर के हम लोगों ने इन पे एंटीजन शुरू किया। तो हम लोगों ने पहले शुरू किया 1:500 शुरू किया, और जैसे कि आप देख रहे हैं यहाँ पे 2 इंजेक्शन इन ए वीक, पहले 2 इंजेक्शन हफ्ते में देते थे हम लोग। और ये बेसिकली जिस प्रिंसिपल्स पे चलते हैं कि स्लोली हम लोग इंक्रीज किए हम लोगों ने कंसंट्रेशन को, और स्लोली डोजेस भी हम लोगों ने इंक्रीज किए। चार्ट है जो शो करता है कि इम्यूनोथेरेपी इनकी चली, और इम्यूनोथेरेपी इनकी जो हम लोगों ने स्टार्ट किया वो मई 2016 से स्टार्ट किया, और कम से कम ये 1.5 साल तक अभी ले चुकी हैं। और लेने के बाद हम और जानने की कोशिश करेंगे कि इनको लेने के बाद जो तकलीफ़ है वो कैसी है। हम लोगों ने इनका फार्माकोथेरेपी भी शुरू किया था, जो फार्माकोथेरेपी में हम लोगों ने इनका जो एंटी इन्फ्लामेटरी नेजल स्प्रेज है वो हम लोगों ने शुरू किया था। और अब हम वीना जी से पूछेंगे कि वो कब तक एंटी इन्फ्लामेटरी चलाई हैं और कब से इनका बंद है। ये ऑलमोस्ट अब कोई एंटी इन्फ्लामेटरी ड्रग्स पे, नेजल स्प्रे पे नहीं है। वीना जी, जो आपने इम्यूनोथेरेपी शुरू की, जो शुरू से हम लोगों ने जो जिस तरह से दिया है, उससे कोई आपको फ़ायदा मिला है?
सर बहुत फ़ायदा हुआ है। इवन अब तो मुझे कभी हॉस्पिटल या किसी डॉक्टर के पास जाने की कभी ज़रूरत ही नहीं पड़ती है। और अब मैं कुछ भी खा लूँ, पहले मैं ठंडा खट्टा अगर कुछ भी खा लेती तो इमीडिएट उसका इफेक्ट हो जाता था, इसलिए मैं बहुत डरती थी कुछ भी खाने से। बट अब मैं फ्रिक्वेंटली कुछ भी खा लेती हूँ, मुझे सोचना नहीं पड़ता कि मुझे क्या करना है। और मैं ना कभी ना कोल्ड होता है, ना कभी खांसी होती है, ना इवन मैं 1.5 साल से कभी डॉक्टर के पास नहीं गई।
जो अभी इम्यूनोथेरेपी, जो आपने इम्यूनोथेरेपी के साथ हम लोगों ने फार्माकोथेरेपी मीन्स की हम लोगों ने नेजल स्प्रे शुरू किया था आपको स्टार्टिंग में, अगर याद करेंगी तो नेजल स्प्रे शुरू किया था। तो अभी क्या अभी नेजल स्प्रे ले रही हैं आप, या नेजल स्प्रे बंद हो चुका है?
नहीं, अब तो काफी टाइम से बंद हो चुका।
कब से अंदाजे कब से आपका बंद है नेजल स्प्रे से?
8-10 महीने से तो मैं वो भी नहीं ले रही।
8-10 महीने से आप नेजल स्प्रे नहीं ले रही हैं। और जो इम्यूनोथेरेपी का जो वायल चल रहा है, वंस इन आई थिंक 4 हफ्ते में एक बार जो चल रहा है वो चल रहा है, उससे आप ठीक हैं, कोई दिक्कत नहीं?
बिल्कुल ठीक हूँ, बिल्कुल ठीक हूँ।
चलिए, थैंक यू सो मच। है ना, थैंक यू। आए थे उस समय क्या दिक्कत? So basically, we just wanted to show the process, how it was done and everything, and that's all for today, I think. ठीक है? Okay, so we close this session. Thanks to all, and tomorrow at what time? 10? 9:30. Acha. So tomorrow 9:30. So you have ample time. You can just enjoy the evening. So thank you so much. Tomorrow directly here only.